Good afternoon, everyone. I'm Dr. Althea Hicks, Grants and Programs Manager here at Jonas Nursing and Veterans Healthcare. I'm grateful for all of our participants today who have shared important research-based knowledge and best practices in caring for our veterans. Next, we welcome to the virtual podium Dr. Matthew Miller, the Acting Director of the Office of Mental Health and Suicide Prevention at the Department of Veterans Affairs. Dr. Miller delivered the very first Barbara Jonas Memorial Lecture in Veterans Mental Health last year at our Scholar Conference. So we are honored and delighted that he could speak to our audience again today. This subject area was of great importance to our late founder, Barbara Jonas. Dr. Miller's presentation is pre-recorded today. If you have any questions, please feel free to submit them in the chat, and we will share those questions with Dr. Miller at the end of the presentation. Now, please turn your attention to Dr. Matthew Miller. Thank you.
Hey everyone, it's Dr. Matt Miller. Nice to be with you. This is a different way of being with the Jonas Foundation and each of you than in years past, but nonetheless, it's still a real privilege to be able to share with you and to talk with you in whatever way possible. This is a foundation group, a mission that I am happy to be a part of and support in this way. And I thank you for all the work that you do. I think last year when I was talking to you, I shared the story about my first chief of staff in the VA. He passed along a lot of important wisdom to me and was pretty influential in my development as my first chief of staff. And I remember he stated the importance of the nurse and the nursing role from administration to the front lines. And he said something along the lines of the fact that nothing gets done without and everything goes through nursing. So Matt, make sure you keep that in mind at all times. And that really is true and appropriate. So thank you for all that you do. Thank you for your interest in serving veterans and applying your skills, and just as importantly, if not more importantly, your heart to veterans and a mission of serving veterans. In that spirit, and today we're going to talk a little bit about preventing suicide and doing so through partnerships between me and you. Partnerships between the VA and the community, partnerships between clinical domains and community-based domains. It takes all kinds and various levels of partnership to truly engage successfully in suicide prevention. We're going to talk a little bit more about that as we progress. So let's start by talking about the state of the situation, situational awareness. You all know in your field and what you do, situational awareness and the value of situational awareness often it can't be underestimated. If you lack situational awareness, what are the potential things that could occur? What might you miss? What might you not see? What might you not be prepared for that we need to be ahead of the curve with regard to? I have numerous unfortunate stories about lack of awareness with regard to situation from my time in the military. I was a captain in the United States Air Force, served as a clinical psychologist during OEF, OIF, starting during 9/11. And a commissioned officer training was an experience. Some of you, I'm sure, can relate. But came to commissioned officer training right out of finishing my degree at Michigan State University. And went from graduation in June to commissioned officer training in Montgomery, Alabama in August. Yes, Montgomery, Alabama in August. You step outside at 4:30 in the morning, my classes just fogged immediately. I remember once I was I was standing in a line, and I was just waiting. All we could do was stand there, and I had one of the flight commanders come up behind me and just stare at me, probably from about this far away off my right ear. And it's like, I was thinking in my head, well, what do I, what do I do with this? I'm obviously doing something wrong, but I have no idea what I'm doing wrong. I'm standing here. I mean, I'm not leaning against the wall. I've already learned that lesson. I've been told that the wall does not need my help standing up. So, okay, got that. My hands aren't in my pockets. I've learned that lesson. I think I'm okay here, but apparently not. So the flight commander says, "What are you doing?" And I said, "I'm standing in line, sir." And he said, "Where are your SOPs?" And I said, "In my notebook." He said, "Why aren't you reading them right now?" And I said, "Oh, because they're in my notebook and I'm standing here in line." And he said, "You should have them with you. You should be carrying them around. You should be using every free minute you have to read your SOPs." Now understand, in commissioned officer training, they have an SOP for everything, including when and how to go to the bathroom. So yes, sir, I permission to go get my SOPs. He said, no. So instead he quizzed me, and I did okay. I didn't do perfectly, and that led to some corrective action. But the lesson learned was, and the point that he wanted to emphasize was, that if you don't know the standard operating procedures and you're not using every minute to be prepared for multiple situations, your situational awareness is automatically behind the proverbial 8-ball. I haven't gone quite to the extreme of incorporating that lesson probably as much as I could, but nonetheless it did stand out to me as notable, the importance of situational awareness. And situational awareness is really important for partnership. What if in a partnership, one understands the situation very differently from the other? That can be difficult. That can be challenging then to work together with regard to the partnership. So partnering together here in the spirit of partnership towards suicide prevention, understanding the state of the situation is critically important. Next slide, Casey. There are a few things I think that are important to know with regard to the situation as it pertains to suicide in the United States of America, and as it pertains to veteran suicide in the United States of America. Number one, I think, theater of operation consideration number one, let's call it, is the fact that suicide is a national problem. It's a veteran problem, and it's a national problem. From a national perspective, we're talking about something here where 27, well, depending upon if you're talking about adults versus overall population, 132 deaths per day due to suicide. 132 deaths per day due to suicide in the American population. It's the 10th leading cause of death in our population as a whole, and it's increased yearly since 2000, 1999, 2000s, going up, 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 and up. It's one of the few within the top 10 that has not shown a sign of decreasing or going down, or gains significantly being made. Furthermore, it's become the second leading cause of death for individuals ages 10 to 24. When I hear that, that's where I really, that's the punch in the gut. That's where I really step back and say, whoa, wow, this is significant. State of awareness and theater of operation fact number 2 is that suicide disproportionately impacts veterans. So even in that context, what we see is veterans are 1.5 times more likely to die by suicide than their same age, same sex peers comparatively. Suicide count has hovered around 6,000 per year since about 2008, but because the veteran population is declining, it's declined about 18% from 2005 to 2018. Because of that, the rates then continue to go up. Right now, the rates are about 27.5 per 100,000, which is unacceptable. Frankly, it's unacceptable. We know that certain populations have even higher rates. For example, the 18 to 34 age group has the highest rate of suicide among veterans. Rates in female veterans, particularly those not in VHA care, has elevated recently as well. Next slide. And another factor, I think, that is important to consider in this. So we have the theater of operations. We have the suicide is a significant problem in the American population as a whole. It's a painful tragedy within the veteran population. And then you have COVID-19, why we're meeting this way here today, and rightfully so. A lot of people have asked recently, very fairly so what's been the impact in this context of COVID on suicide and on veteran suicide? One thing I'll say as a lead off to this very good question is be careful. Be careful with the data, because suicide-related surveillance and data that's valid can take a little while to come in and put all the pieces together. I think we'll have the best picture of what has occurred in 2020 by the end of 2021 and going into 2022. That's particularly true with the veteran population, but the CDC has really strong surveillance methods and database, and allowing those processes to play out across a 12-month calendar and then into the synthesis and analyzing stages, I think is important. Now, it's also fair, though, to take a look at signals and signs and respond to them proportionately in an effort to address the need. towards that end, there are some factors that we're mindful of and are keeping a close eye on. For example, we know that unemployment, occupational instability, financial instability have been a painfully relevant factor for many people, veterans included. We know that unemployment rates have risen literally. We know that housing instability has increased within that time frame. I think there's some statistics which talk about veterans and unemployment, and note that the veteran unemployment rate rose significantly during this time as well. We know that unemployment, housing instability, those are relevant factors too when it comes to suicide prevention. In terms of two factors that are of concern under the heading of lethal means safety, we've seen that alcohol sales have significantly increased since March, particularly online alcohol sales. We've seen that firearm sales have significantly increased since March. So those are factors that we want to monitor and keep an eye on. At the same time, and go ahead with the next slide, please, Casey. At the same time, we take a look at, well, what's going on in the VHA system that can help us to understand the signs and the signals. And that's what this slide highlights. We've so far since March, there's been fewer indications and reports of suicide attempts and suicide deaths in the VHA system. There's been fewer ER visits for suicidal behaviors. Now, we began tracking that with healthcare utilization, thinking, well, maybe this is all because healthcare utilization is down, so that's why we're not seeing as much if utilization is down. And that actually tracked according to theory for the months of March, April, May, and June. But then it's actually in the last month has shown a trend where utilization went up, but attempts and deaths went down. So that's something that we'll have to keep an eye on, but that still provides the illustration of the fact that you get signals, you get things to pay attention to and to adjust to in the moment, but also wait for the full picture. Like a little bit like the Polaroid example, where you take the picture and the film comes out, takes a little while, you can see the image emerging, you can start to make things out, but you don't get the full picture until it's fully developed. Similar principle here. Next slide. So we've talked about, from a partnership perspective, the importance of understanding the situation and together having a shared situational awareness based upon a mutual understanding of the situation. So now let's talk about converting this awareness into a partnership of a plan that may originate at the national level, but ultimately needs to be implemented at the local level. Next slide, Casey. Our plan is founded upon three key tenets. And because these three key tenets are foundational by definition to what we do, I'm going to spend the rest of our time and presentation here organizing everything and by these three tenets and walking through them. The three tenets by way of introduction with more to come. Number one, suicide is preventable. Number two, suicide prevention will require a public health approach. And number three, suicide prevention will require all of us, including everyone within the sound of my voice right now. From these three tenets, we get two aspects of our strategic plan. We get a long-term plan playing out over 6 years and clinical and community-based approaches. And then you get a short-term plan we call the NOW plan, which really focuses on what are we already doing that we need to or could do better. So the long-term plan focuses on what aren't we doing and how can we get it up and running across the next 6 years. The short-term plan focuses on, okay, we're doing these things, how do we do them better and improve upon them? Next slide. So let's start with the foundational element here. Suicide is preventable. This is why you're here, right? If you didn't believe this, you wouldn't be here. If I didn't believe this, I wouldn't be here. And it makes sense to me that this is the foundational bedrock. It's also the one that I struggle with the most. I've told you, and some of you may recall my own story, where this truth also used in the wrong way can be quite damning if you allow it. And I've experienced that. So when I talk about this truth, I want to make sure that we're steering it towards, and we're talking about it as a powerful truth towards the constructive, not as a powerful weapon with regard to the deconstructive. So I've shared, and for those of you who don't know, in my time in the military, I had two close friends at the installation where I was chief of mental health. It was a joint services pilot training base. So we trained Marine, Air Force, and Navy pilots. They spent a year with us, and if they made it, they earned their wings at the end of that year, and then they were assigned to their specific airframe from there. There was two flight instructors, flight commanders as well, who were Marines that I was close friends with. And we worked closely together, we worked well together, and we were a good team. I flew with them, and we worked together on a lot of mental health related sorts of initiatives that were really pretty groundbreaking, I think, in many ways. Anyway, one of my friends, he was, towards the end of my time there, he was tapped for redeployment overseas in a combat zone. And so he went for recall training for the Cobra. And during that time, I found out that he died by suicide. And as the chief of mental health and a close friend, I took that very personally. And there was a lot of blame. And really the way it went was, well, if suicide is preventable, what did I miss? And who is to blame? And what could I have done differently? And those are hard questions to answer, and they don't have quick answers. And so I spent a lot of time really wrestling with that. It was painful wrestling. I don't think that's constructive or productive. I don't think a lot of what we do in today along those lines is where this turns into finger pointing, this turns into blame, this turns into scapegoating. I don't want this truth to be used in that way. I don't want it to be used in the way that says if it's preventable, then who can we blame? The way that it should be used, I think, is to take a look at it from, well, if it's preventable, how is it preventable at the individual level, and how is it preventable at the population level, and then what can we do about it? In my own life, that's what I had to come to. I had to come from switching the finger going this way to saying, if it is preventable, and that is a core truth, what are you going to do about it? What are you going to do about it at the individual level, and what are you going to do about it at the population level? At the individual level, Casey, I don't know what the next slide is. But go ahead and put it up there just in case. But at the individual level, oh, good, it worked out. This is exactly what I was going to talk about. At the individual level, we know that it is preventable. Take a look at our annual report. Some things that stand out in our annual report. The rate of suicide for veterans being treated in the VHA and engaged in care has decreased significantly from 2005 to 2017. That's big. That's notable. That's a high-risk population. So the fact that we have rendered care and we've seen those rates go down with that group, that's important. More broadly, we've seen that the rate of increase for VHA veterans compared to non-VHA veterans has risen slower and lower. And that is indicative of the fact that something's being done right in terms of care rendered with regard to the VHA. You take a look at female veterans, and we see within that there has been an increase, but not with female veterans within VHA care. So all good signs towards the fact that suicide is preventable at the individual person-to-person level. At the population level, we see, and next slide, Casey. At the population level, we see that certain strategies and approaches are effective. One, as evidence in our clinical practice guidelines, is lethal means safety. We know that decreasing one's access to a lethal means for suicide during acute periods of crisis in their lives is life-saving. We also know about 90% of people who survive a suicide do not go on to die by suicide. So there's two implications there. Number one, if you can buy that time, that can save a life. Number two, if you can cut down access to a highly lethal means of suicide, that can save a life. Next slide, I think, gives us a little more information delving into the mechanisms of this. Casey? Here it is. And this is, I think, important for all of us to know. Research has shown that if you take the time, and this is talking to individuals who have attempted suicide, if you take the time between thought and decision regarding suicide, the action, 71% of individuals traversed that path from decision to action in 60 minutes or less. 48% did it in 20 minutes or less. Almost 25% did it in 5 minutes or less. So we know that this is a short window, an acute period here between decision and action in many cases. Furthermore, if you pair that short window, that period of time of acuity, with a highly lethal means, then what occurs is death. And we see that with regard to the triangle shown to the right there of your slide. 85 to 90% of attempts that entail firearms are fatal, whereas that number almost reverses with other means. So again, this is highlighting a key point where if we are able to integrate lethal means safety interventions and approaches applied to short periods in time and highly lethal means, we're going to save lives, and it works. And that goes back to the point that suicide is preventable at the population level, and implementing things across the population addressing lethal means safety. Next slide demonstrates how big of an impact this could have. Take a look at row number 1, firearm. Take a look at column number 3 over, or 2 if you don't count the first one, but percentage of veteran suicide deaths, 70%. You compare that to the column right next to it, to its left, and it's 48%. You can see how firearms are the #1 cause of suicide death in America, but disproportionately so in the veteran population, thus again reiterating the importance of talking about lethal means safety from a prevention, population, and individual perspective. Next slide. All right, so we've talked about the fact that in core tenet #1 that suicide is preventable. Now let's talk about core tenet #2, suicide prevention will require a public health approach. Next slide, please, Casey. What does that mean? What does a public health approach mean? I have a degree in master's in public health, and I have to admit there are times I've looked at that and said, well, what does that mean? I'm not sure I even know what that means. A public health approach means that there's an understanding that to address adequately the issue of suicide, you're going to have to integrate aspects of that which you do within clinical settings and beyond clinical settings into community settings. You're going to have to address what you do in clinical and in community-based settings at the universal level, meaning across the population as a whole, across the selected level, and across the indicated level. So you've got to tailor and change and adapt things according to the risk level that presents. Sorry, I had a pop-up show up here. So our approach takes a look at what we can do and what we need to do across clinical settings and community-based settings. Next slide, Casey. So let's talk here a little bit about some of the specifics. From a community-based prevention approach, what we're talking about here is community collaboration, partnership towards coalition building focused on suicide prevention. I think in a slide or two we'll talk about the goals that unify our community prevention approaches. But our 3 approaches cover different aspects. #1, we have a VISN-based approach, which really should be considered a regional approach, where our medical centers form a region, and together our medical centers combine across the region to integrate into the communities, and community-based collaborations and coalitions, and contribute to the work that they're doing within those community coalitions, reinforcing that which is occurring, and in some cases augmenting that which is occurring. Second is a veteran-to-veteran based approach. The veteran-to-veteran based approach is also built on community coalition and collaboration, but it has it primarily occurring through the mechanism of veterans to veterans, particularly in rural communities. And then we have the state-based approach, which is really captured best by our governor's challenge, where governors of the state appoint and designate a team, and that team is tasked with building a statewide suicide prevention plan for veterans. We, along with SAMHSA, then partner with the state teams to provide them technical assistance and training and consultation to help them implement the plan that they are developing. The clinically based side, what we're really focused on in the next couple of years is increasing the promotion and the production of evidence-based therapies using our clinical resource hubs, meaning telehealth. So increasing access to cognitive behavioral therapy for suicide prevention and other evidence-based approaches using our telehealth hubs so that we can increase access and we're not prone to some of the same struggles that we may have in face-to-face, such as transportation or provider availability or things along those lines. So that kind of gives you an idea of where we're at with integrating and creating this public health approach across clinical domains and across community-based domains. Next slide. This slide provides a good overview, I think, in a Venn-like way of how these approaches overlap and intersect across the national level, the state level, and the community level. But really what I want to highlight here is, so what are they all focused on? What ties them together? There's three goals in our community prevention approach that ties them all together. Number one, identifying service members, veterans, and their families in the community, and then screening for suicide risk. Number two, promoting connectedness and improving care transitions. And number three, increasing lethal means safety and safety planning. And we've talked about that and why I find that to be so important. Next slide, Casey, please. These are some of the outcomes that we're looking for within this in the community and the clinical. I'll let you look at this in your own slides in your own time, but it gives you an overview of the targets. Any good program is going to have a strong program evaluation component linked to actionable and measurable outcome metrics. Next slide. Finally, suicide prevention will require all of us. Next slide, please, Casey. There are a myriad of placements, callings within the nursing field and profession wherein this becomes applicable. Let me walk you through it. As example, in the clinical side, we know that safety planning in the emergency room is critically important. Nursing can play a very important role in terms of assisting the care team in the implementation of safety plan development for individuals presenting in the ER with suicidal behaviors. We know that universal screening for suicide can be really important towards identifying those at elevated risk. And Joint Commission has come out with new standards of screening for suicide assessment. Nursing has a critical role to play, I believe, in this area. We know that integrating primary care with mental health can be very important in the suicide prevention battle. 60% of veterans who die by suicide have a mental health diagnosis, but they're not seen within mental health within the last months of their life. More are seen within primary care within those last 6 months. Integrating primary care and mental health and not siloing them can be a really important step in the healthcare system, and one that nursing can play a particularly prominent role, especially in domains of integration such as care management. So lots of opportunities and possibilities in the clinical domain. In the community-based domain, we know that education regarding lethal means safety. We know that the skill in walking people through awareness of facts to engagement with those facts and application of those facts is critically important within suicide prevention. And that's really a role in the community setting that nursing can help to take a lead within, and fits within their skill set in some pretty unique ways. So I think the remainder of my slides give some ideas here for some resources that we have, and they talk about our theme, which is Be There. And Be There really focuses on the fact that, again, everyone has a role to play, and find your role. This is a group, by my experience in talking with you and interacting with you, who is looking for a role and looking to match your experience, your skills, your heart with suicide prevention and the mission. You may be like me in that you may have experienced something painful firsthand, and you want to convert that into something that does good for lives, one person at a time. With that in mind, I would encourage us back to full circle here and say, let's rally around together then the 3 core tenets. It is preventable. It will require a public health approach, and we all have a role to play. Plugging that, we all have a role to play back into the public health approach. Think clinically, think beyond the clinical walls. And each, and the many that fall under each, are critically important within that which we do. Suicide prevention in the VA and with veterans is not just Matt Miller, thank goodness. It is not just the suicide prevention program. It's the mental health program, it's the health administration, it's the VA, it's beyond, it's all of us, it's neighbor to neighbor. So those are the important take-home messages that I would have for us together today. And again, I want to thank you for your willingness to dive into this topic, to learn more, push yourself, and to find that role. You know, there's a lot of people, myself included, I'm embarrassed to say, before I experienced it firsthand, who run away from this topic, who don't want anything to do with it, who view it maybe as a downer or discouraging. There are anchors of hope within this life-saving and, I believe, eternally important calling that we're in. And I thank you for not running away. I thank you for running towards, and encourage you in your continued quest for finding your role within this, whether it be in the community or in the clinical setting. Thanks for your time.
Thank you, Dr. Miller, for sharing not only this important data, but your point of view on this difficult topic. Again, everyone, remember this presentation has been pre-recorded. So if you have any questions, please feel free to submit them in the Q&A tab. We will share those questions with Dr. Miller. Reminder, we're using the platform Slido today, which allows you to submit questions for our presenters through the Q&A tab presentation. Please note that we will also have several interactive polls and activities throughout today's presentations, so please be sure to participate. I'm pleased to now introduce Dr. Karen Scott, current president at the Foundation for Opioid Response Efforts. With over 20 years of experience in healthcare policy, quality improvement, health service research, and public health, Dr. Scott will talk about the opioid epidemic and its impact on the veteran community. And now I will turn it over to Dr. Scott.
Great, Althea, thank you so much, and thank you to the Jonas Foundation for inviting me to be part of this terrific symposium today. Pleasure to be with all of you and to share some of our experience from the Foundation on this important topic. I want to start with just giving you a little bit of an introduction to the Foundation itself, and then move into an overview and picture of the opioid crisis as we look at it today. The Foundation is quite new. We were started just 2 years ago as a private national grant-making foundation focused on the public health emergency of the opioid crisis. Our focus is on inspiring and accelerating action, developing solutions to the opioid crisis. And we think about that work with a focus on patient-centered, evidence-based solutions, and also by developing work that focuses on provider education, health profession education, payer strategies, policy initiatives, as well as public awareness. This has been our first year of being fully up and running and doing grant funding. I'm thrilled to say that we have awarded already this year 33 grants, and mainly in two cohorts. Our first focus was on supporting projects that would improve access to treatment, particularly for very vulnerable populations. And in a moment, I'll show you sort of where our grantees are located around the country. But as soon as we finished the Access to Treatment grant announcements in March, we, of course, like everyone, pivoted to a focus on how do we respond to the pandemic and what the impact of that would be on the opioid work. In that context, our grants, our most recent grants this spring and summer, have included a focus on how you continue recovery support services in the context of the pandemic, many of those going from in-person to virtual recovery support services, as well as supporting some work on policy evaluation and analysis, so that we really also learn from these extraordinary times to hopefully make care even better in the future. Let's try. Just quickly, as a national foundation, I'm really pleased that we're building up a network of grantees that do cover the country. Some of these projects are very local, focused on particular counties or cities. Others are actually the headquarters of national organizations. So we're building our reach in a number of ways. And I would say our grantee network really becomes a critical source of frontline information for us as well. So we communicate with them very regularly, and it's really one way that we stay informed and help identify where the gaps are and where the opportunities are for us to build our programs and support future work. So just to give a grounding, again, some of the data on what the opioid crisis looks like for us in this country. We often talk now about the 3 waves of the opioid crisis in terms of opioid overdose deaths. beginning almost 20 years ago now. So I certainly have stopped calling this an epidemic. Epidemics tend to rise and fall. This one's been with us for quite a while. And it started, as I'm sure everyone's well aware, with the rise in very strong prescription pain medications becoming very widely available and really fueling the first rise in opioid overdeaths over a period of 10 to 15 years. And while that has leveled off in the last couple of years, it has stayed clearly at a much higher level than where we were in the year 2000. As it began to level off, what we also saw as a wave two was a rise in heroin overdose deaths. And unfortunately, some analysis shows that as we restricted prescription pain medications, many people unfortunately moved to accessing heroin to replace that opioid. Again, we've leveled off a little bit in the last couple of years in terms of heroin overdoses, but again, at a much higher level than we were 10 years ago. And finally, the third wave, or at least where we are now, the third wave of the opioid overdose crisis has been this dramatic exponential rise in overdose mortality due to synthetic opioids such as fentanyl. Being heavily in the drug supply and unfortunately increasingly accessible, very lethal medications. So in a 18-year period, we saw almost 400,000 Americans die from opioid overdose. In 2018, for the first time, we saw a slight decrease in the annual number of overdose deaths, or first one that we'd seen in a number of years, to drop just below 47,000 for the year. But provisional data from the CDC for 2019 is suggesting that we may have been risen to over 50,000 overdose deaths involving some type of opioid by the end of 2019. That's, of course, before we get to data for 2020 and the impact of COVID, which I will come back to later in the presentation. So while much work is going on, certainly much reason for concern and continued significant attention to this issue. We also know that this is played out across the entire country, and while it looks different in different parts of the country, very few, if any, areas of the country have not been touched by the opioid crisis over the last 20 years. We know that's particularly true in the Northeast and New England and in the Midwest and Appalachia, as well as parts of the Southwest. But again, no part of the country really immune from the of the opioid crisis. And as I mentioned, the provisional data from the CDC from February 2019 through February 2020, just really immediately before the impact of the pandemic, began to show a slight rise in opioid overdose mortality towards the end of 2019 into 2020. And again, if you look at the map here, any state that is in any shade of orange to brown indicates that they had some increase in overdose mortality in that time period. So again, really stretching across the country, impacting us nationally. SAMHSA has also just released its most recent national data. This is on the National Survey of Drug Use and Health. This is self-reported data, but does potentially show us some promise in terms of all the interventions that have worked to address those with opioid use disorder and in part help connect people with treatment. Overall, it's showing a decline for those 12 and over of a reduction in those self-reporting opioid use disorder, going from about 2 million to about 1.6 million in 2019. Also really striking in the SAMHSA data released last month, though, is an increase in those reporting a co-occurring substance use disorder and any mental illness, including depression, anxiety, as well as alcohol, particularly alcohol use disorder, as well as opioid use disorder. So an important component for us all to be keeping in mind is that very often we're not talking about one condition, one disorder. We're talking about how to help people struggling with multiple conditions, really challenging conditions. Finally, we're also tracking carefully how many people are connecting with treatment. We know for opioid use disorder, and Dr. Volker, the head of the NIDA at NIH, often says, that opioid use disorder is the one addiction that we currently do have some effective medication, effective treatments for. So a focus on getting as many people who can benefit from that treatment, connected with that treatment, has been a significant part of the efforts through federal funding, state activities, as well as provider systems and health systems. So we are seeing some benefits, some positive impact from that. As you look across these 4 years, an increase in the individuals receiving one of the 3 medications approved to treat OUD, methadone, certainly a longstanding medication, buprenorphine, the newest medication, but one that can be more readily made accessible and prescribed through different clinical settings, including primary care, as well as naltrexone used in particular settings. So that's promising progress. At the same time, we know for the general population that probably only represents about 15 to 20% of people with opioid use disorder who could benefit from the medication. So still quite a ways to go, particularly for more high risk and more vulnerable populations. So what does the opioid crisis look like when we specifically focus on the veterans community? And much of this data comes from different analyses from Veterans Health Administration, from administrative as well as clinical data. And what it shows is a picture of, for both opioid overdose rates and opioid use disorder, veterans are indeed at high risk. They're at higher risk than the general population for an opioid-related overdose, overdose mortality, and at least at the same or higher risk for struggling with opioid use disorder. This analysis shows that for also a significant increase, so similar to what we saw for the general population, a significant increase in the rate of opioid overdose mortality in the 6-year period from 2010 to 2016. That's the top gray line, the dotted line, right at the top of the chart. What's also notable is that most of that, as we went through from 2010 to 2016, that heroin became a significant driver, as well as the synthetic opioids such as fentanyl. So again, mirroring the data that we saw for the general population, a similar pattern for the veteran population here. Additional analysis of that data shows an opioid overdose in the veteran population rose to, in fact, a total of 56% higher by 2016 compared to 2010. Age adjusted, that looks even more dramatic, at nearly 80% increase in that time frame. With, again, the focus largely being on the increased access and the lethality of the synthetic drugs such as fentanyl, as well as from heroin. In terms of the prevalence of opioid use disorder, there's some analysis from epidemiological studies, which shows an estimate of about over 400,000 veterans compared with 2.5 million non-veterans with opioid use disorder in the 2012-2013 data. What we know about OUD is it associated with younger ages, with those with lower income, fewer years of education. Notably, in the case of the analysis of veterans, minority race, Black, Hispanic veterans were also more likely to be struggling with opioid use disorder than their white counterparts. For all of those with opioid use disorder, we know it's also much more highly associated with having other psychiatric and substance use comorbidities. Again, an important theme for us to be mindful of. We also know that, we know that data from VHA says between 2010 and 2015, the number of patients within the VA system diagnosed with OUD were about 68,000, and by 2017, that number was over 69,000, heading towards 70,000. So significant numbers, again, mirroring or exceeding even the comparable non-veteran general population. So why is that? A number of the risk factors for opioid use disorder and opioid overdose are certainly even more so present in the veterans population than in the general population. And these are not isolated, siloed risk factors, as we all know, but a lot of overlap and intersecting issues that can challenge and increase the risk for opioid use disorder, particularly around chronic pain, post-traumatic stress disorder, homelessness, as well, contributing to OUD, also contributing to suicide risk. And we know that for the majority of the time of the opioid crisis, those in rural areas with perhaps more limited access to services as well as to opportunities were at higher risk as well. So let's look at some of these risk factors in a little bit more detail. Lost my slide advancer. Okay. So in terms of chronic pain, the estimates are that 2/3 of veterans served within the VA health system, about 2 million veterans in the 2010 to 2016 period, were identified as having chronic pain. There are also, again, high associations with depression, with PTSD, and with substance use. Surely that means that this is a population that is even more likely than the general population to have been exposed to prescription opioids, high-dose painkillers as part of or as the sole way of managing their pain. Some data analysis from the National Health Interview Survey, again, really illustrates that points veterans more likely than non-veterans to report severe pain in general, over 9% compared to 6.5% of non-veterans. And that's true, was found to be true at every age, except for the oldest age group here, those over 70. Notably as well is that women veterans reported even higher levels of severe pain than their male veteran counterparts, as well as to women in the general non-veteran population. So a lot of chronic pain, a lot of challenges in terms of managing chronic pain, especially musculoskeletal, and the risk of significant exposure to pain medications, prescription medications to manage that pain. Next, we know that the prevalence of OUD is higher in those with PTSD, and there's an intersection between PTSD, chronic pain, as well as opioid use disorder. And what we also see from data analyzing both OUD and PTSD prevalence throughout the 2000s, from 2004 to 2013, again, a steady increase in both of those diagnoses and in seeing both of those diagnoses in the same population. Finally, I want to touch on the risk factor of homelessness. Data shows that nearly 18% of homeless veterans in the VHA system had been diagnosed with an opioid use disorder. Over fully a third of veterans with OUD have experienced homelessness or housing insecurity. And this is a population that is at higher risk, not only for OUD, but a greater risk for HIV, for schizophrenia, and alcohol use disorder. At the same time, it's a population that is much less likely to be connected with treatment that may be effective and helpful in terms of the opioid use disorder. So how do we mitigate some of these risk factors and the impact they're having as it drives opioid use disorder and risk? I want to talk a little bit about pain management, how we should be thinking about pain management. We should be thinking about how we identify some of both the comorbidities and social factors, social determinants that are driving the risks of opioid use disorder and overdose, and think about how we treat at every level and interaction in the healthcare system, how we can be connecting people with treatment and recovery services. Here's a slide from a report from Veterans Health Administration showing improvement in changes in the clinical practice approaches to chronic pain management over the last few years. What's promising is to see the dark purple line representing any opioid medication provided for chronic pain, as well as the green line with the squares, which shows a reduction in long-term opioid therapy. And at the same time, an increase in use of physical therapy and occupational therapy, an increase in psychosocial treatments, for example, slight increase in use of antidepressants. All of these are very consistent with the CDC guidelines, which came out a few years ago on revising the clinical approach management of chronic pain, and this reduction in exposure to prescription opioids, which we know are not the best way to treat chronic pain long term, also certainly reduce the risk, and is promising in terms of the clinical interventions for this population. In terms of thinking about comorbidities and social determinants and risks, I just wanted to highlight here the opportunities for again at many different entry points into the healthcare delivery system, and certainly for all of your roles, to be thinking about how we screen, how we do histories that can really be holistic and take into account a recognition, or be looking for where the intersections might be, to signal a higher risk of opioid use disorder or opioid overdose. Certainly that includes how we take a substance use history, including current use as well as misuse. Misuse can include keeping a bottle of prescription medication, using it in ways that's not directed on the label, and or using medications that were prescribed for someone else. But I particularly wanted to highlight the expert tools, screening and brief intervention and referral to treatment. Those of you, clinical settings may also be used to screening for depression with a PHQ-2 and a PHQ-9. This is a similar sort of approach in terms of a brief screening tool. It can lead to additional questions where indicated, as well as brief counseling and helping to identify and connect people with treatment. Equally important, though, in terms of screening are the family and identifying the family and social history stressors, housing, employment, as well as stressors connected to the military history. Again, along with physical and mental health history, these are all items that will help direct a treatment plan, as well as identify specific risk factors. And now in terms of connecting with treatment within the VHA, access to treatment is available. Government reports show over 500,000 veterans in 2018 receiving some substance use treatment. And specifically in terms of the medications, medication-assisted treatment for OUD, we see a steady rise in the number of veterans receiving this treatment within VHA. And in fact, as a percent of the population with OUD receiving treatment, veterans are, VHA is doing better than the general population. Nevertheless, still a lot of opportunity for improvement and addressing some of the barriers, including having providers available who are trained in OUD treatment, particularly in more rural areas. One thing to think about as well, though, is not only that you have that treatment available in healthcare settings, but how do we reach particularly the most vulnerable of the veterans populations? And that can often be by really thinking about much more multimodal, comprehensive ways of linking people with treatment and doing the outreach and, in fact, bringing the treatment to where people are. What's often referred to as really doing very low barrier access to treatment. One example of this, the VA in the Connecticut healthcare system, is a mobile community-based access team bringing together medication treatment and psychosocial services. The team includes physicians, nurses, social workers, a peer support counselor, and uses lots of different innovative strategies, including technology, telemedicine, as well as case management and peers to initiate engagement with veterans, as well as keep them engaged in care for a long enough period that the treatments can actually have an impact and help drive a different trajectory for people. We're funding similar work to test some models, and one example of that is with the Thomas Jefferson University Medical Center in Philadelphia, focus on a homeless population, urban minority, including veterans, to both hear from them what will help keep them engaged in care and build those programs, and again, particularly with models of outreach and bringing that care to the populations. I also wanted to touch on the peer specialist training. This is an area that we've begun to do some additional funding in as well. And Ballad Health is one system in Tennessee and Virginia that's rapidly expanding their training and use of peers in different settings. And not only do peers have the lived experience, but if you can really develop your workforce of peers, you can have peers that are essentially specialists themselves and really match with specific life experiences of patients who are just beginning treatment and a recovery process. And that includes certainly developing a cadre of peers who are veterans themselves, who have those lived experiences to connect with others as they start that journey. So to wrap up, certainly paying attention to opioid use disorder and the opioid crisis as you think about veterans' health is absolutely appropriate. It's a problem that based on the data we have, and we can always use more recent and strong and data for action, but the rates are at least as high as they are in the general population for OUD, and in fact significantly higher for overdose mortality. There's some critical risk factors that we can think about how we mitigate that help drive that, particularly around the levels of chronic pain in the veteran population, levels of post-traumatic stress disorder, and social factors such as the high risks of homelessness and unemployment. In addition to mitigating those factors, though, we also can be thinking about the multiple doors and ways that we can make treatment for OUD accessible for the veterans population. I want to end, though, with adding the next layer in terms of what we're all thinking about in terms of the opioid, crisis. So I feel like everything I've just said sort of takes us up to February 2020, and then what are we seeing? We're seeing that more than 40 states and localities have recorded increases in opioid-related deaths since the pandemic began earlier this year. We're seeing data from NIDA showing that people with substance use disorders are more susceptible to COVID and its complications. And while we're seeing an increase in use of telehealth that can be very good in terms of improving access to care, we're also hearing about a lot of needs and potential gaps that we need to be paying attention to as well. It's a lack of technology, infrastructure, internet, cell phone data plans that allow patients to actually connect through telehealth. And so we're asking as well, what does that mean for low-income populations, for highly vulnerable populations? Is it going to increase equity to and access to care, or is it going to increase some of the disparities that we already have across vulnerable populations? We also know that wraparound and recovery services are traditionally very reliant on interpersonal and group model programs, and some of the funding that we've been doing is to try to help organizations figure out how you go from in-person to virtual and maintain some of those linkages, which are so critical to people's treatment and recovery from OUD. Racial disparities in access to OUD treatment are being highlighted now, just as racial disparities in all aspects of health and healthcare have been highlighted by COVID. As we think about peer recovery coaches, we're really interested in what the needs of those coaches, that workforce that's become so critical to helping keep people connected to treatment, what their needs are and and what supports they need while they're out doing the job of supporting others. And again, as always, the need for real-time data so that we can continue to be responding to what's happening in these extraordinary times remains critical. So I think I am just out of time, but I thank you all and look forward to any discussion we can have, or to asking you to certainly come to our website and learn more about the programs we're funding. Thank you.
Dr. Scott, thank you so much for sharing that great presentation. We do want to just take time for one question. One of the questions that came in is about any specific training programs you may be available for care providers, more knowledge in treating patients with opioid use disorder, any other organizations or national programs that might be available?
Sure, that's a terrific question. I'll direct you to actually one of our new grantees, which is so on our website. There's a project based at the Massachusetts General Hospital with Dr. Alistair Martin. His focus has been particularly on expanding the waiver training, which is the training that prescribers need, so including nurse practitioners, to be able to prescribe buprenorphine. But he's increasingly, that's a great starting point. It's also an access point. They have their own website for treating OUD, treatoud.org, and is a great access point to get information about additional ways of both getting the training, and then once you have that training, how do you start to put that into practice in different clinical settings?
Okay, great. Thank you so much. And then we'll take one more. Should providers automatically screen for mental illness if signs of opioid use disorder seem apparent, and vice versa?
So I would absolutely advocate for that. I think the data is really supporting that these are, we need to be very much thinking about these as about the comorbidities, that these conditions did not occur in isolation. Some comment that while we have an opioid crisis, there are often other factors that are driving why some people are so susceptible to taking a pain medication and becoming a use disorder versus others. And from the data, from the SAMHSA data, from CDC data, we increasingly are seeing, and particularly for younger age groups, that the intersections with depression, with anxiety, with trauma are significant. If we see one, we should be worried about the other.
Great. This information was very helpful today. Thank you, Dr. Scott, for that firsthand, close-up perspective on the opioid epidemic and its impact. So we'll continue moving right along for our next presentation. We Dr. Laura Anderko, member of the Jonas Nursing and Veterans Healthcare Advisory Board. Please, Dr. Anderko, who is the Robert and Kathleen Scanlon Endowed Chair in Values-Based Healthcare at the School of Nursing and Health Studies at Georgetown University, and a professor and senior faculty fellow in the Center for Social Justice. She is a White House champion of change for public health and climate change. Dr. Anderko is also the director of the Mid-Atlantic Center for Children's Health and the Environment, Region 3, PEHSU, based at Villanova University. Dr. Anderko will tell us more about common environmental health exposures faced by veterans and their families. And now we welcome Dr. Anderko.
Thank you, Althea, for that nice introduction, to Jonas for the invitation. And I want to do a call out. Happy birthday to Mr. Jonas. My dad turned 91 this year, and it's a great time to celebrate. Over the next 45 minutes or so, we're going to be talking a little bit more specifically about common environmental health exposures. Dr. Rugen did a fantastic job in providing a broad scale overview of some of the risks that military personnel and their families are exposed to. And the Mid-Atlantic Center for Children's Health and the Environment has a number of case studies. I'll share one or two of them with you around military families, and hopefully we'll wrap up our discussion with information and solutions on how to address some of the things we may be seeing in the healthcare setting or the public health setting. Quick acknowledgement, this material is funded by a cooperative agreement with the American Academy of Pediatrics and the Agency for Toxic Substances and Disease Registry, as well as the EPA. And also views expressed in materials shared and what I say do not necessarily reflect the official policies of the Department of Health and Human Services. Just a quick introduction to the Pediatric Environmental Health Specialty Network. We are a national network. Currently, our center is the only one that is nurse-led, but we're moving towards changing that. We serve Region 3, which is the yellow area. We serve 6 states. There is a pediatric environmental health specialty unit that serves your state. We are always interested in chatting, particularly with nurses who are encountering questions or concerns about their community, regardless of where they live. There are 2 primary goals of each one of those 10 centers. The first is to provide consultation and referral. So we often get emails and calls about a particular exposure, and then we provide guidance and referral and information for that family, for the physician, whoever might be contacting us. And the second part is outreach and education. Just like today, we're always willing and interested in offering information about a variety of environmental health exposures and how they might impact reproductive and children's health. So today we're going to talk about common environmental exposures of military families and those health risks. We are going to focus on 2 of the most common environmental exposures. And then we're going to discuss methods for conducting health assessments to determine exposure and risks, what screening tests are available, how health providers can manage cases and refer based on those individual findings, and always the importance of policy and advocacy in protecting the public's health. So what are the gaps? Well, those of us in healthcare and health, or who are health professionals, are well aware that we do not get any if a little or any training or education in how the way that environmental health is impacting our families and our patients. Sometimes we may learn about lead, which is a legacy metal, but overall, we're really not aware of how the environment can impact people's health. The other identified gap is also the fact that we don't learn a lot about the culture of the military experience. And I loved some of the earlier presenters in walking us through that and becoming more aware when we talk about cultural competency. The culture of military living is one that we often ignore. And then another identified gap is a lack of exposure data for service members and families. And Dr. Rugen also talked about the environmental health tracking system that the VA has in place and hopefully will be utilized so that we can look over time at what those exposures may mean for the military personnel and their families. So today we're going to talk about 2 common environmental exposures and those health risks, discuss strategies to reduce those exposures, and outline basic methods for assessing, screening, and managing cases. So why are military families at risk of environmental exposures? Again, the speakers earlier today did a fabulous job of walking us through some of the various wars and potential exposures, such as Agent Orange. This actually goes way back to the Civil War. And what I am going to focus on today are how families are impacted by these exposures and what we might want to be looking for and acting on as we do our assessments. This is a picture from 1967 of a charred wreckage, which came after a power surge led to fire and explosions. One of the things we'll be focusing on today is the use of firefighting foam in military bases and how that can not only impact folks that are using that foam, but literally people living downstream and in that community surrounding the military bases. So first we're going to focus on lead. We know that lead is a highly toxic metal that poses a serious threat to health. It's a neurotoxin, which means it impacts the nervous system. While our center focuses on childbearing families and children, it can lead to a number of neurological problems regardless of your age. In military life, there are a number of reasons why military families may be at more risk for exposure. The primary exposure pathway is housing. And, any home that's built before 1978 has lead paint in it. We did not ban lead from residential paint until 1970s. And so a really important question to ask folks is, first of all, have you been in the military? Anybody in your family in the military? Where do you live? How old is your housing? One of our very first case studies of the center was a military family, high-ranking official who was being transferred to the state of Virginia, which is one of our states. The reason it was that the housing lead poisoned the entire family, the father, the mother, the 2 kids, at such an extent that there was permanent neurological damage. It was a big, sprawling, beautiful old home that was getting renovated, and the lead dust created problems for everyone in that family. And so we're going to walk through lead poisoning and some of the things we can do and some of the educational points that we can make with families. But lead paint is still with us. There's a picture here of someone holding soil. If you live in an urban area, lead was in gas for many, many years. That stays around for a very long time. And if you're planning on planting a garden, particularly something that you're going to eat, you really need to remediate that soil, just scrape it away. You can test it, but chances are pretty good if you live in an urban area where there's a lot of traffic, it still has lead in it. It can be taken up by tomatoes, for example. Also, be aware if you have an old home with lead paint on the outside, that paint flakes and dusts off and lands in the soil. And so if you're going to plant a garden, plant farther away from the street and from the home. And then last but not least, water. We know about lead in water from Flint, but this is a pretty common problem for cities that are older where there was lead piping that was installed, and there's a lot of lead piping in the DC area where I work. In fact, the city of DC is beginning to replace those lead pipes that lead to the home. Always let the water run for a little bit before you use it. And there are some other tips here in a minute. So what do we know about lead? It's a neurotoxin, as I said, can cause damage to the brain and the nervous system, can lead to behavior and learning problems. We like to teach school nurses that if a child is difficult, hyperactive, not doing well in school, maybe complaining of a tummy ache, he or she needs to be tested for lead, particularly if the neighborhood is one where there's older housing. We may see delayed growth in puberty, hearing problems, headaches, kidney problems, and an increased risk of high blood pressure in adulthood, and a greater chance of failure to graduate high school. So overall, if a child experiences lead poisoning, it can last a lifetime, depending on the level of lead poisoning the child experiences. We talked about the middle section. The last bullet point here is we may see children that drop out of school. We may see an increase in ADHD. We may see aggression, violence, substance abuse, and injury. And so it's really important for us as health professionals to be aware of where those neighborhoods are, where our families are coming from, and to be sure that we ask the right questions related to housing. So we talked about where lead could be coming from. Happily, with the law to ban lead in gasoline, which occurred several decades ago now, we are not seeing as high of a level of lead in people, particularly in urban areas. But we are still seeing it in water from the lead pipes. We're seeing it in the soil, also from, as I said, the emissions from years ago, as well as flaking paint. And so lead paint dust inside is also incredibly important, particularly if the windows were painted with lead paint. Kids chew on those windowsills, hang on it, they flake off, and the dust is everywhere. Also in renovations, and we'll talk about that in a bit. One thing to remember is never to use hot water for cooking or drinking ever, because the hot water will leach the lead out of the pipes. And so again, always a good question to ask folks if they know how old their housing is. If it was built before 1978, it most likely has lead paint inside. Another source of lead is firing ranges and ammunition, right? So bullets have lead in them. Maybe families or people within the family enjoy hunting or firing ranges. One of the centers in the Pediatric Environmental Health Specialty Unit Network has done a lot of work around firing ranges in teens, which has become very popular in the Northeast. These are typically indoors. There's no fresh air that comes in, And once those bullets are used, that lead is in the air. And also handling the bullets can be problematic. So keep that in mind as well as we're talking about hobbies or even occupational exposure. So what can we do related to our practice? We need to assess, screen, and manage those risks, and we'll talk about that. But the primary thing to keep in mind about environmental exposures is we often cannot treat once someone is exposed. So the most important thing is to assess, to screen, to see if there's a test where we can see if they've got levels of a contaminant in their body and to help reduce those exposures. So public health, primary exposure, primary prevention is the way to go. So that means we need to raise awareness. We need to educate our families, our policymakers, our people in our community to help reduce those exposures and to advocate for healthy public policy. And we'll talk a bit about that, particularly as we move into the next exposure. We need to also be aware that there are special risk groups that are much more likely to be exposed. Military folks, absolutely, and their families for reasons we just discussed. But those folks who have occupations, maybe it's shooting or hunting, maybe it's leaded glass windows and stained glass hobby. Also, folks who are foreign born, we're finding in particularly places in Maryland where there are high numbers of refugees that use certain kinds of makeup or alternative medicines, very high in lead, very high in lead. And so keep in mind that cultural practices may in fact increase one's risk for exposure. Another item is particularly from Mexico, pottery that hasn't been glazed properly, that has high lead in the paint that was used. So we need to do our health assessment. We need to ask the question about housing. We need to understand that HUD and other groups have funds available for remediating lead within a house. And we also need to keep current. CDC has an advisory committee on childhood lead poisoning prevention. There are a number of local communities. There was one right here in DC this week that met around lead and housing. So get yourself involved, even if you're not part of a committee. Get on their listserv and see what's available to folks within your community. Screening guidelines for children that are enrolled in Medicaid, regardless of their lead risk. Universal screening is required at 12 and 24 months of age. That means two screenings by the age of 2. It's paid for by Medicaid. We have worked with the DC Department of Health, and unfortunately, there are a lot of practices that do not do this, particularly when children are coming from areas of high risk. The EPA, or excuse me, the CDC recommends screening based on regional variability and risk factors. But we encourage all families to screen at the age of 12 months and 24 months. There's a lot that happens in those first 2 years. Kids picking up a lot of stuff, putting it in their mouth, chewing on windowsills, those kinds of things that can put them at much greater risk. How do we prevent exposure? Again, this goes into education and raising awareness. Have families wash all fruits and vegetables prior to ingestion. You can wash pacifiers bottles and stuffed animals in the dishwasher. Keep them free of lead dust, particularly if kids are putting the toys in their mouth. Water filtration, you'll find that as a theme today. And it doesn't have to be pure, it can be Brita or whatever. These water pitchers will take out about 99.9% of lead. There's also filters that will screw on to the faucet, and they're more money, but you can also get a water system under the sink that will take out lead and a number of other contaminants in the water. Nutritional interventions, it's really, really important, particularly for kids, to eat a diet that has adequate iron and calcium in it. This will help bind with the iron and remove it from the system. On the flip side, avoiding foods that are high in fat content is a good idea because that helps retain helps retain the lead in the system. There's a great little booklet that's free online from the EPA. It was first published in 2001, and they have a slightly newer version. Same information, just different pictures, but it's called Fighting Lead Poisoning with a Healthy Diet. And within this little booklet that you can download, epa.gov, you will find recipes that are kid friendly and ways to encourage kids to eat those foods that will help reduce any lead in their system. Personal behaviors are always important. We need to avoid using imported ceramics and cosmetics. I can tell you that there's a website called EWG.org, environmentalworkinggroup.org, that gives a list of those cosmetics with toxic materials and offers some alternatives. Any red lipstick, almost always, even bought in the US, will have some amount of lead in it. Lead is very cheap and it helps colors brighten. So check those out, even for your own personal use. Avoid the use of alternative medicines, particularly if if they are foreign made. Avoid consumption of international food products, such as Mexican candy, which is a real problem in the population we serve. You can buy this, in the dollar store venues, and unfortunately, to get that candy to be bright and colorful, lead is oftentimes in the candy. Clean and remove your shoes before entering the house. This isn't just for lead, it's for all sorts of things that from exhaust and pesticides that are sprayed outside. It stays in carpet for decades, even if you clean your carpet. So just take your shoes off, have a little pair of slippers next to the door, and encourage families to do the same thing. It's usually when we chat with families, we like to provide them tools to help them determine if their home is safe or if there are areas of concern. These little lead check swabs, you can buy them online, you can buy them at a local hardware store or a big box store. They're about $10 for 2 of them. You snap them in half and there's a little liquid that comes out. You can put them on plates, you can put them on the wall, and if it turns red, it means there's lead in whatever you just tested. It's always a good idea. Beautiful china from my grandmother from World War II, and it was filled with lead. So, and that gets taken up into crystal and like I said, pottery and dishware and china that has lead in the paint as well. Also, it's really important for pregnant women who are living in a home should not initiate home renovations. I had a dear friend when I worked back in Wisconsin who had a baby. They were renovating this old house, the nursery. Baby came home, baby was fine. Baby came home and after a few weeks was sluggish and lethargic. Took the baby to the pediatrician who said, "Oh, this baby cannot have lead poisoning. You live in a really nice area." And she took the baby to another pediatrician who said, "Yeah, your baby's loaded with lead." So keep in mind that not everybody has the wherewithal, particularly during the pandemic, to make several trips. always ask the question, how old is your home? And, are you renovating? Is there anything that you're doing that might increase the risk for lead exposure? And this brochure is on EPA.gov as well. The last thing I want to share is that in 2015, CDC decided to include lead poisoning as part of the IDEA program, an Individuals with Disabilities Education Act, which means if a child is formally diagnosed as lead poisoned, they are seen as eligible for special education. And when you're working with families, make sure they understand this. Because it has shown that it really greatly increases their ability to succeed in school. And the only appropriate approach to lead poisoning is to prevent the problem. Okay, moving on to a newer contaminant, although it's been around for about, 30, 40 years now, is perfluoroalkyl substances. And some of you may have heard of this through the popular news media. There were a couple movies that just came out called Dark Waters and The Devil We Know, which are now available on streaming facilities if you're interested in it. But what was being found several years ago, so we've been working on this for 6 years now in Region 3, was that especially military-based neighborhoods and communities had high levels of this contaminant in the water. And this was as a result of using AFFF firefighting foam to whether it was actually to put out a fire or whether it was part of a military practice. And these were the communities that we started out with so long ago, 6 years ago. Now we fast-tracked to 2020, and the CDC, the ATSDR, the Agency for Toxic Substances and Disease Registry out of CDC, has selected these communities to do an exposure assessment. So if you practice or live or work in these areas, you may be getting a call that says, can we come in and check the dust in your home or your facility? Can we check the water to see what the levels are? It is a national problem. And this comes by virtue of EWG.org, as I mentioned earlier. You can see the purple dots are the military sites. The blue dots are where we know that there's high levels of PFAS. You see in Michigan, there's a lot of blue. That's as a result of a hush puppy factory that had high levels of PFAS contamination. And then the pink red dots are other known sites. So what are they? This is a family of chemicals, thousands of chemicals. They tend to have long carbon chains, and the longer they are, the more permanent they are. They're called legacy chemicals or forever chemicals, you might have heard. And there was a lot of work done on a couple of these years ago, but there's a lot of interest in the range of these chemicals because unfortunately, these chemicals are found in almost all of us in the US based on national randomized studies done by NHANES. So why are these chemicals important for us to be concerned about as nurses? Well, first of all, there's widespread human exposure. It may affect the developing fetus and child. There are long half-lives, meaning it can last up to 32 years, depending on the type of chemical. So once you get exposed, it's there for a long time. And because of that, it may bioaccumulate. It may increase cancer risk. And the levels that we're finding in drinking water in those places with the dots exceed what the EPA has recommended as the lifetime health advisory level. So where does it come from, right? Because I'm a public health nurse and we need to prevent exposure. So we purchase stain-free carpeting because we want nice carpeting. But the reality is, though, that stain-free chemical that is used has PFAS in it. Water-resistant fabrics, such as our coats, non-stick cookware. There's a picture of the AFFF firefighting foam. Packaging for the food that we like that's greasy. These all create conveniences for us, but it is ubiquitous. It's in almost everything we use. So we have to be really very conscious and careful about what we purchase and what we expose ourselves to. And in addition, fish that are swimming in water that's contaminated with PFAS will take this in as well. And so it's important to look at any fish advisories, particularly if you enjoy fishing as a hobby or if your families fish for subsistence living. We also know that it goes through the cord blood, goes through the breast milk, and so there's a lot of research occurring on what this may mean for babies long term with moms who may have high levels of PFAS and also occupational settings. And quite honestly, that's where this first got discovered many decades ago now, was was making of the Teflon pans through DuPont. So we know that folks in occupational settings and in the military, folks that are using this firefighting foam are much more likely to be exposed to this chemical than the general public. So other health effects, and this is not a comprehensive list, and there's a lot of research going on. So this just sort of gives us a scope of what we know. It can affect growth, learning, and behavior of infants and older children, can lower a woman's chance of getting pregnant. It can interfere with the body's natural hormones. It can increase cholesterol levels. It can affect the immune system, and it can increase the risk of cancer. One of the things that's being researched right now is immunotoxicity and developmental toxicity. In particular, if children have been exposed, will those immunizations be taken in by the body at levels that will protect them? We also know that because it competes with the immune system, that can be a problem for folks who are being treated for any range of health issues that may suppress the immune system. Preeclampsia or high blood pressure in pregnancy is a strong association. So if you're working with pregnant moms, always a good idea to just ask about whether they are part of a military family or military personnel and and where they live in regards to the water. We also know that there is an increase in low birth weight, depending again on the type of PFAS chemical and the level. We also know that it disrupts the endocrine system, and it can lead to neurodevelopmental disorders and obesity. We're also seeing an association between an increased risk of asthma and type 1 diabetes. So what does this mean for us as nurses and practitioners? This actually article came out just March of this year. The first slide I showed said 400 military installations. Now it's looking more like 600 military installations could be contaminated with PFAS. There is a link in this article that shows an updated list that has been identified by the Department of Defense. Again, just like lead, we need to do just general nursing practice, which is assessing, screening, managing, educating, and advocating. So what are some of the key things that we can do? Drinking water filters, again, this time those little water pitchers don't work very well for this particular chemical family. They're much smaller. So what one needs to do is get either well, I'll have a slide following this, underwater or under sink filter or a whole house filter. If mom is giving baby a formula, try to convince them to use pre-mixed rather than using contaminated PFAS water. They may not know if their water is contaminated, but if they do know, they should use pre-mixed formula. Controlling dust in the home, which I always laugh at, because if I could do that, that'd be great. But dust control in the home is important, particularly if you have carpet that's treated, or other consumer products that you know are treated, because they do tend to dust and flake off after time. As I said, check your local fish advisories. You can look this up, usually on your public health department website. Avoid certain consumer products, and be sure to, again, test your garden soil if you're going to be using it for gardening, because it will be taken up again by plants. And if the PFAS is in your drinking water, it's also in the water that you're using to water your soil and your garden. Not going to go through this in detail. There is a fact sheet below, and my email address, or the email address for the center, just send us an email and we'll send you the fact sheet. It lists all of the products that will have been researched and will take out the PFAS chemicals. There are two kinds of water filters: granulated activated carbon or reverse osmosis. Work the best. These have, believe it or not, been researched by a few universities and have been shown to significantly reduce the amount of these chemicals. So again, think about what you're purchasing and what you may be exposing yourself to. Also, very important for military families to be aware of how they might have some control over their exposure if their loved one who is working with this foam does not. Is there medical testing? There is. It's very expensive. It's not typically covered by insurance. What we can learn if someone does get a blood test, or how much they have, how it compares nationally. But the truth is, we actually don't know what level is safe and what level might lead to a certain health outcome. So you're basically going to know if you have it or not and what your level is. The truth is, we all have it. Some of us in higher levels than others. We might be able to do an assessment of where it might be coming from if the levels are high, but it really isn't going to be able to help lead us to a particular diagnosis or a plan of treatment. Right now, ATSDR is in the process, as I said, of doing exposure assessments as well as health assessments. So they will be contacting folks in these communities about getting a blood and a urine test and seeing if they might be willing to get their home tested for the dust and water for the PFAS. I've participated in these town hall meetings. They're quite informative. The ATSDR is very interested in working closely with communities to address their concerns, and they do plan on taking action based on the information they gather from this national survey, both exposure and health assessment surveys, and they're always, at least our experience with Region 3 folks have been always engaging and ready to help answer questions about this, this issue. So this is really, really hard to read. But again, if you go to the website up on the top, it says environ.org. There is a lot of information by the Alliance of Nurses for Healthy Environments, the only national group for nurses that is dedicated to environment and health. You'll see the first question on that exposure assessment is, was your house apartment built before 1978? Why we ask the question, and steps to reduce risks. All right. There is much more to this form, and it is very helpful in walking you through what questions to ask and why to ask them. There's also a website by the EPA called EJ Screen. It is designed for communities to use to determine how polluted their community might be. This is a snapshot from a town in Delaware. You can see on the left what the national lead exposure levels are, and on the right what they are in the specific communities. The red areas are high lead levels in the housing. So it might be helpful to learn more about those communities that are being served, particularly in military installations, and to check out what those risks might be. They do air pollution and water pollution as well as lead. Superfund sites, things like that. So in the next few minutes, I'm going to wrap up with something I found as I was preparing for this lecture, which goes way back 20 years from the Institute of Medicine, which is now the National Academy of Sciences. They did a report, and they concluded that those who serve and are deployed are at greater risk of environmental and occupational exposures. And so they create a list of 6 strategies that, quite honestly, I think should be done for all military families and all families. The first is to systematically evaluate any non-battle related risks associated with activities and settings of deployments. The reality is there's something called take-home pollution or contaminants. So mom or dad comes home after working out in the field with some of these chemicals. They may in fact be bringing it in on their clothes. Kids hug mom and dad, and then it becomes problematic. Strategy 2 is to collect, manage environmental data and personnel location, look at biological samples and activity data. It sounds like, based on Dr. Rugin's lecture, that the military is moving in this direction to collect that data over time. Be sure to consider how military leaders can determine risk, manage those risks, and communicate risks to the personnel. And nurses are trusted professionals. We need to be in there and help these leaders make those connections. Accelerate. Strategy 4, accelerate implementation of a health surveillance system that spans the service life cycle and that continues after separation from service. We know these exposures, like PFAS, can last decades after exposure. Implement strategies to address medically unexplained symptoms in populations that have been deployed. I would say also those who are living in military bases and housing. Strategy 6, and final one, implement a joint computerized patient record and other automated record keeping that meets the information needs of those involved. And again, the military is working on that and will be very, very helpful as we look at long-term impacts from exposure. All right, we have a polling question. So the question is, I have a little thing here. Okay, military families are at risk of illness from exposure related with or associated with. We have a brilliant group. 100%. Yes, it's all of the above, both from deployment, housing, water contamination, and personal behaviors. Great job, everybody. And I want to thank you. This is a little slide where if you're in need of CE, there are hundreds of webinars and online courses related to reproductive health, childbearing families and children, and the environment on this website. Check it out. There's also resources should you need more information. And I thank you very much.
Thank you, Dr. that question. We do have quite a few questions. And so, in the sense of time, we're just going to answer a few. And so, one of them that came in is, have been long-term effects identified from depleted uranium exposure in veterans from the first Gulf War?
Great question. Not sure. I'm embarrassed to say I'm not sure. That is not something that we see in the center.
Okay. And well, given us a lot of resources, so we may be able to go look into some of. And
I'm happy.
watch
I'm happy
the-
to research it. Yep, and answer that question after today, if that works. I'm
Okay,
not sure how to do that, but yeah.
sure. Okay. And then another question is there any research here into burn pits or screening from associated exposures?
Yeah. Yes. This is no pun intended, a hot topic. And in regards to screening, the first question obviously is to ask if somebody has served in the family or that person, whether they were exposed. We know that any sort of burning creates all sorts of pollution and respiratory issues. There is an emerging body of science around this. Again, I'm happy to link folks with that if they'd like. I know we're a little short on time, but I think to simplify things, screening should always start with simple questions about where people live, what sort of work they're doing, and what sort of exposures they think they may have had. Most folks in the military have some sense that something maybe wasn't right or might have been detrimental to their health. So I think really just asking those first few questions, but I'm happy to link this viewer up with research that's specifically looked at burn pits.
Great. Thank you so much for that great presentation. And it was very informative. And now we're going to move on to our next session. And so next up, we present Kayla Williams, a senior fellow and director of the Military, Veterans, and Society program at Center for New American Security. She will lead us through the difficult topic of sexual trauma in the military and what providers need to know in caring for patients who have experienced military sexual trauma. Please welcome Kayla Williams.
Thank you for that very warm introduction, Althea. I really appreciate it. I'm very honored to be invited to join you all today. I want to make very clear, first of all, that I am not a healthcare provider myself. I am an Army veteran, and I used my GI Bill after I served, which included a year-long deployment to Iraq, to earn my master's degree in international relations. So do not have tremendous healthcare expertise. However, I did spend about 8.5 years as a researcher at the RAND Corporation, which included work on their study of military sexual trauma, which includes which we'll get to a little bit later, exactly what that means. But I worked on a study at RAND assessing prevalence. And I've also done research, as Derek very kindly mentioned this morning, about the needs of minority veterans. I also spent 2 years at the Department of Veterans Affairs, where I ran the Center for Women Veterans. And happy to give you an overview about this topic, and then hopefully have some time to address some questions at the end. So I hope I hit the right button. Next slide. Did that go correctly, technical director? Okay, thanks. So before we get started, I want to start with a quick question. What is the main thing that you want to take away from this presentation? You can go ahead and go to that app and use it to answer with just one word or a really short phrase about what you're hoping to take away from my session today. And I can keep talking a little bit while you're typing that in. I do just want to make sure I have everything sketched out, what I'm going to cover. But if there's something in particular that somebody wants me to address, I do want to make sure that I try to get to it. Precedence, I'm going to think that might mean prevalence, but I can talk a little bit about whether there's preceding sexual trauma before the military as well. Trauma-informed care, advocacy, great. Supportive services, proper resources, some statistics, and screening. Great. I think I'm going to get to almost all of those. So this is very helpful. Thank you so much. And let's move back on to the next slide. I'm going to see if my thing works. It seems to be the other direction. Okay, so here's an overview of what I'm going to be covering today. I'm going to talk about the definition for military sexual trauma, its prevalence, some of the consequences, screening, referrals and resources, and then where you can go for more information, because it's a really huge topic and I definitely won't be able to get to every single detail while I go, although the presenter before me went into every single detail about exposures. So it's big shoes to follow. First, let's dig into the definition of MST. So first polling question that's multiple choice. What do you think MST means? Do you think it's assault by one service member upon another, being sexually assaulted while on duty, being harassed or assaulted while in the military? Or do you think it's when any woman is raped by a soldier? If you can go ahead and go to the polling app and answer now. All right, so some of you may still be voting, but so far it looks like the voting is for the the option being sexually assaulted while on duty. So let's move forward and talk about what the actual definition of MST is. So military sexual trauma refers to both sexual assault or repeated threatening sexual harassment that a veteran experienced during their military service. It does not have to have been committed by a fellow service member, and it's experienced by both men and women. A few other things that are worth noting about MST. This definition is actually based in the law. It's not something that VA came up with by itself. It's written into U.S. code, which requires VA to provide counseling, care, and services to veterans to overcome psychological trauma resulting from physical assault of a sexual nature, battery of a sexual nature, or sexual harassment which occurred while the veteran was serving on active duty for training, or on inactive duty training. Sexual harassment is further defined to mean repeated, unsolicited verbal or physical contact of a sexual nature, which is threatening in character. Thank you. It's important to note that that term is not used by the Department of Defense. The military services have their own language that they use to define various behaviors that are prohibited by and punished under the Uniform Code of Military Justice, or UCMJ, and various policies. Most of the services treat sexual assault and harassment separately and don't lump them together into one uniform definition of military sexual trauma. And it's also important to know that military sexual trauma does not need to have been reported while the veteran was serving. Under the law, the determination is based on the judgment of a mental health professional employed by VA as to whether or not it was MST. Let's dig now into prevalence. First, we'll jump into the third polling question, which is the second multiple choice question. So how common of a problem do you think MST is? About what % of veterans overall do you think have experienced MST? And while you're voting, I want to note that prevalence is really complicated. So when I'm giving you some information about prevalence on the military side, I'm going to be talking about active duty and overall numbers. I'm not going to be digging so much into service specifics and things like that. All right, so looks like most people are guessing that it's around 25%, and some people are assessing at about 50%, some a little lower than that. All right, let's move on. Thank you. So first I'm going to talk about active duty personnel, what they're saying in surveys, confidential surveys, in terms of past year sexual assaults. Since 2012, between 4.3 and 6.2% of active duty women and 0.6 and 1.2% of active duty men have reported a past year sexual assault. That equates to over 20,000 service members being assaulted in 2018. And it's worth noting that only a little over 6,000 of those officially reported their assaults. When service members do report, retaliation is relatively common. In terms of harassment in 2018, about 24% of women and 6.3% of men indicated past year sexual harassment. And these are interconnected issues. Active duty women who experienced sexual harassment were at 3 times greater risk for sexual assault than those who did not. And junior enlisted women are at the highest risk. Next slide. So we talk about men and women differently in here, and it's also important to think about how the veteran population breaks down by age and gender. Female participation in the military has grown really substantially since 1973, and women veterans skew a lot younger than men. We have a median age of 51 compared to 65 among men. And by 2017, we made up about 17.5% of the total force, up from just 15% in 2000. It's not a huge amount of growth, but some. So the percent of women veterans is going to grow in coming decades. You can see on that slide this huge chunk of the male veteran population that's over 65. And as these veterans who served during the draft era pass on, the percent of women as a share of the veteran population is going to grow really substantially. But right now, men still make up about 90% of the veteran population. So there are roughly 2 million women veterans out of roughly 20 million veterans. So when we talk about what are the estimates of military sexual trauma among veterans, used to be that there were roughly equal numbers of men and women who use VA care, who screen positive. That's changed a bit because as the number of women veterans has grown really substantially. So VA's national screening program of all VA patients, in 2015, it was 1 in 4 women and 1 in 100 men. If you look more specifically at post 9/11 veterans, OEF, OIF veterans, like my era, it was 41% of women and 4% of men. And it's also really important to remember that in the civilian population, over the course of a lifetime, over 27% of women and around 11% of men experience unwanted sexual contact of some kind. So veterans may have complex trauma histories that include both military and civilian sexual assault. I want to particularly also call out the issues of LGBT veterans. According to some surveys of active duty personnel, about 7% of women and 2% of men identified as gay or lesbian in the military, 7% of women and 1% of men identified as bisexual. These individuals are at significantly increased risk of experiencing sexual assault. So 9% of LGB women veterans reported, active duty women, reported a past year sexual assault compared to only 4.8% of non-LGB women. 3.7% of LGB men reported past year sexual assault compared to just 0.4% of non-LGB men. Transgender status is currently a little uncertain in DoD, and it was not assessed in that survey. But the civilian research shows that transgender individuals are also at significantly increased risk of sexual violence. So worth being attuned to the fact that these intersectional issues can really come together, and that LGBT veterans may be at even increased risk compared to the rest of the veteran population of having experienced military sexual trauma. Let's dig in a little bit to the consequences. So next up, if you can go back to your polling app, what do you think are some of the conditions that have been linked to MST in the research literature? So what do you think are some of the consequences that folks who have experienced military sexual trauma might experience as they go on with their lives and perhaps become your patients? see how the voting might come in. Not sure if it's a little bit of a lag or if people are just afraid to be wrong. Don't worry, I don't know your names, so I won't be able to call any of you out specifically if you get it wrong. I'm just teasing right now. Give you another couple seconds to see if anybody wants to vote on what conditions, or poll on what conditions they think have been linked to MST before I move on and give you the answer to this one. All right, this one's a little slow, so let's move on. I think people are tired. I built in polls to try to keep you alert and engaged, but I know it's really hard. There we go. All right, so everybody recognizes PTSD as a risk, and a lot of folks recognize depression is a risk, and slightly fewer folks recognize that pregnancy complications and cardiovascular disease are also risks. But the correct answer was all of the above. All of these have been linked to MST. Let's move on. Next slide. One thing to bear in mind, I'm going to talk about mental and physical and some other consequences, but as we move forward, keep in mind that MST itself is an experience. It's not a diagnosis, and it's not a mental health condition. Veterans can have a variety of reactions in response to MST, and although trauma is a life-changing event for many people, folks are also remarkably resilient after experiencing trauma, and many individuals recover without professional help. Others may generally function well, but continue to experience some level of difficulties or have strong reactions in certain situations. For some veterans, the experience of MST may continue to affect their mental and physical health in significant ways, even many years later. And overall, it is associated with lower quality of life. When it comes to mental health and MST, post-traumatic stress disorder is strongly correlated with military sexual trauma. PTSD is actually more strongly associated with MST than either combat trauma or civilian sexual assault. But it's not the only mental health diagnosis that can result from MST. Other frequent diagnoses include depression, including perinatal depression, generalized anxiety disorder and other mood disorders, as well as substance use disorders. And I know you got an entire presentation earlier on suicide, and I think that presenter also mentioned that military sexual trauma is a significant risk factor for suicide. At least one study showed that women with a history of MST were 70% more likely than those without to have suicidal ideation. So definitely something to be aware of and mindful of when you are treating patients who disclose a history of military sexual trauma, especially if they also have PTSD or depression. When it comes to healthcare, some of the health outcomes associated with MST could include physical injuries directly linked to the sexual assault itself, which could vary really significantly depending on the nature of the assault. Higher rates of other physical health conditions include headaches, GI difficulties, sexual dysfunction, chronic pain, chronic fatigue, heart disease, as I mentioned earlier, insomnia, and eating disorders. Among women, PTSD is also linked to several different pregnancy complications, including gestational diabetes, preeclampsia, and preterm birth, postpartum depression, anxiety, and perceiving the pregnancy as difficult. I also want to talk about housing instability. MST is a risk factor for homelessness. Of homeless veterans using the Veterans Health Administration, nearly 40% of women and over 3% of men had experienced military sexual trauma. They had significantly higher likelihood of almost all mental health conditions than other homeless men and women had, including depression, PTSD, and other anxiety disorders, substance use disorders, bipolar disorder, personality disorders, suicide, and among men only, schizophrenia and psychotic disorders. Of Iraq and Afghanistan veterans, almost 10% of those who reported MST when they were screened for it experienced homelessness at some point within the next 5 years after they first sought that VA care after separation from the military. And that's more than twice the rate of homelessness than those who reported no MST when they were screened. About 12% of men who reported MST were homeless at some point within 5 years after seeking VA care, compared to, and about 9% of women who reported MST went on to experience homelessness. So what's the best way to screen for MST? do you think you should just ask your patient, were you ever raped when you were in the military? I'm being a little flippant, but you would be surprised at how many lay people have asked me that in casual settings, like over a beer at the bar, and somebody hears that I'm a woman veteran and just asks me that. I'll recommend against that approach, especially in a healthcare setting. It's not conducive to a warm relationship or easy disclosure. VA assesses MST using a 2-item screen. The first is, while you were in the military, did you receive uninvited and unwanted sexual attention, such as touching, cornering, pressure for sexual favors, or verbal remarks? And while you were in the military, did someone ever use force or threat of force to have sexual contact with you against your will? This is a universal screening assessment for sexual harassment and assault, and research has shown these items to be highly sensitive and specific. I would urge you to think carefully, depending on especially the type of setting you're in, whether you want to ask those questions and if you're confident that you're going to be able to respond appropriately if somebody answers yes. I can tell you as a patient that I've been really frustrated when I've been asked these questions at VA and then the provider doesn't say anything. If I say, yes, I experienced pervasive sexual harassment while I was in the military, and they just tick it down and then move on without asking if I'd like to be referred to additional services or if it's causing any problems in my life. I don't necessarily, as an individual, want to be asked about something this intense if it's not going to lead to any sort of follow-up or any sort of additional access to resources, or if I don't feel like the provider is going to do anything with that piece of information. So just bear that in mind. So if you do choose to screen for MST and someone does disclose, where can you refer them for specialized care or for other support? First up, I really urge you to keep these 2 resources on hand. You can print the slide out. You can probably go to VA and request that they send you cards or magnets or some other things. They usually have a lot of materials that they're very willing to share with this information on it. First is the Veterans Crisis Line, 800-273-TALK, Veterans Press 1. That's something I actually urge folks to memorize, be able to spit it out at any moment in time. That is staffed 24/7. Veterans can also text 838-255, and their website has a number for deaf or hearing impaired, as well as a chat function online. For women veterans specifically, VA has a Women Veterans Call Center that is staffed exclusively by women and can help women veterans get information about VA care, VA benefits, and other services, as well as with direct referrals to women veteran program managers at VA medical centers all around the country. That one is not staffed 24 hours a day, 7 days a week. The hours are up there on the slide. And that one also is not a crisis line. If somebody calls the Women Veterans Call Center experiencing suicidal crisis, they will be transferred to the Veteran Crisis Line. The Women Veterans Call Center is more for help navigating and accessing general services. So let's talk a little bit about what VA and VHA specifically can do for veterans who have experienced military sexual trauma. I believe Derek mentioned this in his presentation this morning. For those of you who have been on all day, RAND assessed the capacity for civilian providers to deliver high quality, culturally competent care, and very few met their exacting criteria. Only 1 in 3 psychotherapists reported that they'd been trained and received supervision to deliver at least one evidence-based practice for PTSD and at least one for depression, to give just one example. So VA can be a really powerful resource for veterans in that they provide evidence-based treatment for a variety of different conditions, including specifically MST, which is universally screened for at VA. It's important to know, especially since not all veterans still know this, that treatment for all physical and mental health conditions related to MST is free, and veterans may be eligible for that MST-related care even if they're not otherwise eligible for VA services. Eligibility for VA care is an entirely hour-long presentation all by itself. Can be very complicated and tricky, and especially for those who have served in the Guard or Reserve component, and it can be very confusing to veterans. So it's important for veterans to know that if they've experienced MST, they can get care for that condition even if they don't have a service-connected disability, even if they don't necessarily qualify for other types of VA care. Every VA medical center has an MST coordinator who can help veterans access that care. And VA mental health care includes psychological assessment and evaluation, medication, individual and group psychotherapy, which during the pandemic, they've pivoted very, very rapidly to dramatically expand telehealth, as well as residential or inpatient care. Veterans should also know that as patients at VA, they have the right to request to see a provider with the gender of the patient's choice. I often will fall into the habit of talking about women experiencing MST and men as perpetrators. Statistically speaking, that is the most prevalent type. However, that's certainly not the full story. Women can be the perpetrators of sexual assault. Men can be victims of sexual assault. And any VA patient can request to work with a provider with the gender of their choice. VA also has a lot of whole health options, including yoga and massage and Tai Chi. My spouse is a veteran, and he was, when we had 2 small children under age 3, he was going and doing golf as recreational therapy for like 4 hours every Sunday for a while. I was very suspicious that this was actually therapeutic, but it really did help him learn to manage his emotions in a better way. So I was very chastised to learn that my suspicions were misplaced. And also important to know about vet centers, which are somewhat separate from big VA. They tend to be in more locations, a little more accessible, and their care at vet centers is completely confidential. It does not get linked into the overall medical record. So if somebody is in Guard or Reserve and goes back and forth from active duty to veteran status and is worried about their file being seen, vet centers can be a really good option. I do want to acknowledge, though, that VA is not the best choice for everyone. And when I've done research, stakeholders have routinely reported that women can be reluctant to seek services at VA medical centers, which can be perceived to be male-dominated spaces and less sympathetic, understanding, or welcoming to women. Women with a history of military sexual trauma are more likely to find this to be a barrier to care, and may prefer not to re-enter an environment full of prior military men. As noted, though, very few providers in the civilian setting are familiar with the effects of MST. Experience with VA staff and providers, but also fellow patients, can affect veterans' willingness to continue to engage with the VA system, trust the care they receive, and seek that care in the first place. VA's own research indicates that 25% of women veterans have experienced inappropriate or unwanted comments or behavior, typically by men patients, while at VA. Women veterans who reported harassment at VA were less likely to report feeling welcome there. That has been associated with them delaying or missing getting health care. Interviews have been that we've conducted supported VA's conclusions. One of our stakeholders said specifically about experiencing harassment at VA, a woman veteran doesn't necessarily go back. If they have a negative experience, they're not coming back. And we have a quote up there. I have a quote up there from another woman veteran about some of the challenges at VA where they may not necessarily be harassed, but you can get that question, oh, are you here with your husband? Oh, are you sure you deserve care? Do you belong here? And that sort of thing can be really difficult when you're trying to get that care to be made to feel unwelcome, purposefully or accidentally. So for those folks who do not want to go to VA for care, there are other options. I listed 3 suggestions for mental health care that's available in the nonprofit sector that could be available free or occasionally with their. It can get very complicated with whether or not, for example, Cohen wants to seek reimbursement from insurance, but 3 options on the mental health care side in the nonprofit sector include Cohen Veterans Network, which I've personally used since the pandemic has gone on and provided telehealth, very easy to access. Headstrong, which my husband has used and had very good success with, and Give an Hour. There are also, for veterans who don't necessarily want or need specific mental health care, but want to be able to connect with other veterans, possibly get involved with advocacy as part of their journey to recovery and finding meaning and pushing back on what they may have experienced. And a couple of nonprofits that may be beneficial for those veterans include Protect Our Defenders and one called Combat Sexual Assault. I've clearly given you just a really high-level overview, and there is a lot more to learn. So I want to give you some resources of additional places you can go for more information. So there's a whole list here. VA itself has a community provider toolkit that may be useful for you. There's a lot of general information from them on military sexual trauma as well. The VA, which is Veteran Benefits Administration, has information about how veterans may be able to seek disability compensation related to conditions caused by military sexual trauma. I put a link for that up there. And then also, if you're interested in research about women veterans' health, there's a tremendous amount. It's really exploded in the past 15 years or so. And if you're interested in digging into some of that, there's a link up there for that. Psych Armor also has some free courses for civilian providers. They have one specifically on MST. They also have some on military culture if you want to improve your military cultural competency, and on a wide variety of other topics. And then if you're a big nerd like me, I would like to really suggest that you sign up for the Military Reach newsletter. I put a link down there. They send out a monthly newsletter where they capture some of the recent studies that have come out about service members, veterans, and military families. They provide a really brief overview of what the research says. And then they also grade it, which I think is super helpful. They talk about how high quality and how digestible the research is. And you cannot read every single medical journal every single month. So this is a great way to get exposed to some of the highlights of the most interesting and relevant recent research, as well as an assessment of how much confidence you should have in that research. So really want to put a plug in for that resource. That's all I have. I'm happy to open it up now for questions, and I'm going to trust Althea to moderate that. And I also know that you're running a little behind. So when we finish questions, if you want to move on, I'm not going to be hurt if you want to try to steal some time back so that you can get a little bit back on schedule this afternoon.
Sure, no problem. We appreciate that. We do have a few questions for you. Thank you so much. That was a very informative presentation. So one of the questions that has come in is, how do you handle potential of retaliation? There have been recent stories of military members being harmed after reporting their sexual trauma.
So it's a great question, and I think it is worth kind of teasing apart a bit whether you're talking about veterans or service members. So absolutely, on the service member side, this is very well documented, very high rates of retaliation, which is why reporting is so low. I think I talked about how few service members actually make official reports, and a big part of that is this fear of retaliation. Usually, by the time somebody is in veteran status, that is not going to be as significant of a concern. Once they've left the military, there are fewer ways for them to be professionally retaliated against. However, if you are treating somehow an active duty person who is concerned about that, or a veteran who may be transitioning back and forth between active duty and guard status, for example, or just for any reason has those concerns, I would refer them to the nonprofit resources that I suggested, because these are not going to be linked to their active duty military file. They can have a higher expectation of confidentiality. When I was active duty, because I did military intelligence, I knew that if I sought mental health care, I did not have confidentiality. That because I held a security clearance, that certain things, if I disclose certain things, that they may go to my command. And so if you have a service member who has that type of concern, sending them to the civilian sector, to a nonprofit resource, is a way that they can get the care that they need without having those concerns. Vet centers as well. Vet centers are able to treat active duty service members and have confidentiality. vet centers do provide non-medical counseling. So it's important to bear that in mind. They're not going to be, it's not psychiatrists, they're not prescribing medication, but they at least can provide that non-medical counseling and support to service members who have experienced military sexual trauma.
That's good to know. And thank you so much. And then one more question we have is, do you find it easy to get male patients to open up when they've experienced MST, military sexual trauma?
Yep. Again, I'm not a provider myself, so I can't talk about that side of things. However, the research is very clear that men who have experienced sexual harassment or assault in the military are much less likely to report. They have different experiences of MST as well. They are more likely to have experienced multiple instances of assault, have multiple perpetrators, have it occurred while it was on during duty time, and to perceive it as under a framework of hazing. So all of the stereotypes, I think, that we hold about men in our society also come together to make it much harder for men to disclose, whether it's to healthcare providers or when making a formal report. And anecdotally, in the advocacy work that I've done, it has been much more challenging for men to come forward and be public and publicly disclose their experiences with MST. And so definitely think it's important to be particularly conscious of those additional barriers and challenges that men may be experiencing if they've gone through experiences related to military sexual trauma.
Okay, great. Thank you so much for sharing all of this great information today and for leading us through what is already a difficult topic. Your perspective on the impact on military veterans has left us with important information. So we really appreciate your time and sharing this information with us. And at this time, we'd like to thank Senator Kirsten Gillibrand, who has shared a letter of support with us in recognition of today's conference. Senator Gillibrand is a member of the Armed Services Committee of Congress, and we appreciate her support today. We will now have a 5-minute break before we continue to the program, and we look forward to seeing you back here shortly. Thank you. Welcome back, everyone. It's our pleasure to introduce our next two on growth and Jeannie Blaustein, who will lead us through the topic of the principles of palliative care and how we can ensure whole person care for our veterans. Dr. Dawn Gross joins us from the University of California, San Francisco, where she is an attending physician, co-founder and CEO of Dialogues, and the medical director of ANX Hospice. Dr. Gross joined Dr. G. who, in addition to being a member of the Jonas Advisory Board, is an adjunct faculty member in the psychology department at Pace University and is the founding board chair of Reimagine. Please welcome Dr. Gross and Dr. Blaustein.
Hi, everybody. I'm Jeannie Blaustein, and it's such an honor to be here, both as an advisory committee member and as a representative of Reimagine End of Life, which is where I met Dr. Dawn Gross, who I'm going to introduce in just a moment. And I'm very excited to have a few minutes to share with you what Reimagine is all about, so that you can have this as a resource for yourselves and for your colleagues, and to know that you may have something that you want to share on this platform as well, and we would look forward to that with you. I met Dr. Gross through Reimagine End of Life, and it's no coincidence because both palliative care and Reimagine are fields and initiatives which are holistic and multidisciplinary and integrative. Reimagine looks at things from a 360 point of view, all around, looking at well-being and working with the body, the mind, the heart, and the spirit. And we do that, like palliative care, by asking questions about what matters to us, how are we prepared, what does legacy mean, and what does living well mean to me today. So with that in mind, sorry, I'm just getting my remote online. Oops, wrong way. How do we do this? What we do is we actually host what we're proud to call revolutionary community-driven gatherings, both virtually these days and in person in cities around the country and these days around the world. And I'm very proud to say that we've worked with some of the finest nursing schools, as well as many of you may know the work of Carolyn Jones, a filmmaker who recently produced Defining Hope about hospice nurses and In Case of Emergency, which just premiered this week. We've also worked very, oops, I keep doing that. Sorry, folks. We've worked with veterans communities, both in New York and San Francisco and across the country, creating advanced care planning sessions specifically for veterans and the issues that they hold as they're thinking about end of life. We have worked with the New York Department of Veterans Services to support veteran caregivers. We've worked with programs to support veterans living fully through the end of life, and building on the creativity of Reimagine and our 360 approach, we've worked with to support veterans in their own creativity and experiences. So the principles of holistic care and supporting the entire person are also at the heart of palliative care, which is why Reimagine has been so honored to partner with and elevate the work of some of the country's most talented and wisest physicians, nurses, chaplains, and thought leaders. And in that context that I met Dr. Gross, who, as you just heard, is both the founder of Dialogues, a very innovative program helping to bring advanced care conversations to individuals and collective groups as well as companies. She is the founder of a podcast, Dying to Talk, and a WKAL radio in San Francisco, and truly is a visionary who recognizes that although most people say that they don't want to talk about end of life and death and dying, in fact, everybody is often thinking about it, and particularly these days. She's one of the leaders in engaging ways to explore these tough topics through difficult conversations, and I think we are very, very lucky to have her with us here today. So please join me in welcoming Dr. Dawn Gross.
Thank you, Jeannie. It is such an honor to get to be with all of you today. And Jeannie, thank you for the invitation, as well as Miss Mary Fiore. Thank you. So the topic, as you've already heard through Dr. Blaustein, that we'll be discussing over the next 45 minutes or so, is how to bring palliative care, that specialty, which I'll define for you in a little bit, into all of our lives as individuals, as healthcare providers, as caregivers, as family members. Do we need specialty training, or is there an aspect, or many aspects, as we'll learn, of palliative care that's available to all of us right now? So before I begin, as per protocol, as an academician, I need to disclose, which you've already heard, that I am founder and CEO of this benefit corporation. We started Dialogues a couple of years ago, two colleagues of my own community, that when we realized the desire to have conversations to support what some feel might require a bit of courage, they may feel uncomfortable but are so necessary, it really outstripped what I could do as an individual despite my deep-seated efforts. So we needed to expand, and that's what Dialogues is all about, as you heard from Jeannie. So before I begin, I want to invite everyone to give yourselves a gift and to turn off any other distractions that might be tantalizing you, like your cell phones, your pagers, if you're allowed, to even consider moving outside if the weather allows, to be present to this moment and the people around you, the sounds around you, the world around you. We're going to dive into something that ultimately is all about our presence. And one of the greatest gifts that we have to give as well as to receive is that of our own. And with that, to have you and your presence be known to me, I'd love for you to answer this poll question of how are you right now? Appreciate. I'm seeing a lot of good. If you're familiar with the word clouds, the more a single word is repeated, the larger it gets. So it's good to know that many of you are good. It can be hard to come by these days. I'm certainly finding good. Fine. Yeah. Well, excellent. I'm hoping surviving 2020. The fact that you're here is testament to that. Excited to learn. I am excited to learn too. I've been learning so much today in this conference. So a little bit more to learn yet, I hope. Fantastic. Comfortable, healthy, great, stable. That's impressive. I could learn how to be stable. Grace. Content. Okay. Do I see a cozy? Okay. Okay is an authentic answer. I think sometimes when we ask the question, how are you? We can say good and okay pretty passively. And I'm hoping that actually what you're communicating with us right now is the authentic. Yeah, I'm only okay. I'm not great. I'm not terrible. I'm right in the middle.
I love laugh and cry easily. I think that speaks to a very honest appraisal. Laughing and crying easily.
Laughing and crying easily. I find myself there often, Jeannie. All right. Thank you so much. We will have many polls, so stay tuned. Moving along with our presence. Here's where I'd like to begin. So my commitment, my passion in life is to discover what matters most to people and to have their wishes come true. And the truth is, the only way to do that is by creating a practice of curiosity and having the courage to ask. So while I have been given some pretty high-level insider information on what it is I think many of you are excited to learn, or at least some of you are excited to learn, I'm also really curious to know what you actually are hoping to learn and why you're here sitting wherever you are or standing, perhaps your treadmill running. What is it you're hoping to hear and learn in this time we have together? So here's another poll right away for you. Share with me, right? Whatever it is, what are you hoping to get out of this session right here, right now? So resources. I'd love to know what kind of resources. We'll get a chance for Q&A. Maybe you can be more specific what resources that you're hoping for if I don't automatically give them to you with my telepathic powers. Anything else? Mental stillness. Wow. To soak up whatever I can about this topic. Wow. Application of palliative care, insight and understanding. How to bring up the first time to discuss this difficult conversation. Yes, I really am excited to talk about that and hopefully transform one's relationship to this being a difficult conversation. Dying homeless on the street. Wow. Wow. That's important. What would it be like if we didn't have that as a topic? What is my power? What is in my power? Oh, a lot. That's awesome. Excited that you're curious to know what's in your power. Best practices. Wow, Jeannie, these are moving quickly. Are you capturing all this? A little less cray-cray. I'm all for that.
How is palliative care different from hospice? Is it different? What a great question.
Yes, I promise to answer that. And if you don't feel you have an answer that you can provide yourself by the end of this, then please reach out. That is an absolute objective. And I want everyone to be able to communicate the difference. And I will already tell you, there is a difference between hospice and palliative care. Great. All right. I am thrilled with what you're hoping to get out of this session. And here's how we're going to go about addressing that. So just to give you an overview, we're going to begin with, oh, did it go too fast? I apologize. Who we are. My slides. There we go. Who we are. We're going to start there. Who we are. And then why we serve as individuals, as caregivers in the healthcare system, and specifically in hospice, and most importantly in palliative care, that perspective, as well as then this practice. How do we practice a practice? I think you notice in my training as a physician, I'll use the language, the practice of medicine, right? This is how we taught our work. We don't call it the work of medicine, although sometimes it feels that way. But it's often always communicated as the practice, and my more favorite, even the art of medicine, which we'll come to. All right. So with those in mind, let's start with who we are. And I would suggest that we all start in the very beginnings of where we came from. So who I am defines actually how I practice medicine. And it begins in the beginning. And so this is a photo of myself and my father, and I'll let you guess who is who. And I think this photo speaks to the origin of my life story in so many ways. And the first, that I came from a very loving and nurturing background with parents that cherished me and were curious about what I was seeing in the world, as well as sharing what they were discovering in the world at all times. And so this moment captures my father engaging with me, wondering what am I seeing, as well as so excited to share with me what he's seeing. And that's how he interacted with me the whole of his life. So that leads me to this picture. One of the things my father did when I was about 6 years old was he had what I now appreciate was an advanced care planning conversation. Now, he didn't call it that, and I don't know that he even would have had the language to call it that, but I now realize, in fact, that's exactly what he did. So my father was the administrator for a large healthcare system, not so different from the VA, called Kaiser. And he was very proud and passionate about the work he did. And he loved it when I would come to visit him at work. And one day he brought me in and showed me a new development he was very, very proud to deploy. And that was the creation of this series of rainbow colored lines on the floor throughout the hospital. And he explained to me, he said, Dawn, here's what I realized is that people have a hard time navigating the hospital to find where they're. In reality, people don't, when they're walking to find directions, wise are naturally looking is down at the floor where their feet are going. It seemed to me if we could color-coded stripes like the yellow brick road. Really sick people are in the intensive care unit. And where we were standing in that moment is where those two lines diverged. And he paused and he said to me, now, Dawn, I want you to know something. I would never want to go down where that green line goes. If I were to ever become so seriously ill, I would much rather have that time, energy, and money spent on my grandchildren's education. Now, what I heard as a 6-year-old wasn't that my father was talking about his own mortality and that he was thinking about the end of his life, which was many decades, unfortunately. Which meant that I would have to become a mother, which was a far more terrifying proposition. And yet he planted a seed of one of his most treasured values, family, legacy, as well as education. Photo is of my father now holding his first granddaughter, Isabel, wish of his coming true. Now, he knows, and I know I did not have children to satisfy, but someone's wish when you have granted it is incalculable. My daughter is now a junior in college. Again, satisfying his legacy wishes. Now, as we worked on who we are and how the world is as compared to where we know we came from, we currently, in this age of COVID, are being perceived as healthcare providers as heroes. And that may or may not give us great joy or energy in our daily practice. I would suggest that there's something far more sustaining, and that's of our colleagues, the people that we have the honor of serving with. And so while I, having been as a medical trainee, imagined I would wear a mask on such a frequent basis at work, and more we practice reflective, the people get the opportunity to serve with. So recognizing our team around us, cultivating that team wherever we are, is actually one of the secrets of palliative care, but it need not be restricted to palliative care. So here are some images of my career thus far. The guests are care or hospitalists, most of whom
Hi, everyone. Thank you so much for your patience. As you know, in this new virtual reality, we're all working remotely, so we are having some minor technical difficulties at this time. We do expect to be back with you very shortly, so thank you very much. Please stand by.
Well, hello again. And thank you for sticking that out. I apologize for the connection troubles, and thank you for your patience and your persistence, which really is speaking to the core tenets of palliative care in so many ways. I will pick up from where I left off in brief. This slide is a demonstration of my first advanced care planning conversation that I had with my father at the age of 6, when he, as a hospital administrator for a large organization, not unlike the VA, took me to work proudly and demonstrated one of his proud accomplishments, which was realizing that people wanting to navigate the maze of the healthcare physical body, the hospital, as well as the system itself, it was challenging. And one of the things he realized he could do was to create an easier form of navigation. And he realized that when people are looking for directions, that it was unnatural to look up to the walls, the ceilings, what have you, for guidance, that where people naturally look when they're walking is down at their feet. And so he created a series of rainbow lines to guide people to different locations of the hospital. And he was sharing that with me. He showed me, for example, these two lines running in parallel for a portion of the hallway. He said, see, if you follow this pink line, it will take you to where babies are born. And if you follow this green line, it will take you to where really sick people are in the intensive care unit. And we paused at that moment where those two lines diverged. And he knelt down to me and he said, and I want you to know, Dawn, that I would never want to go to where that green line leads. That if I were to ever become that sick, I would rather the time, energy, and money be spent on my grandchildren's education. And I can tell you as a 6-year-old that I didn't hear him talking about his own mortality. He was healthy. He was not anticipating the end of his life in any immediate future. He lived many more decades. But he was telling me what he values most. And in that moment, what I heard was that he expected grandchildren, which was a terrifying notion because that meant I realized that I needed to become a mother. And this is a photo of years after that conversation, when in fact, I did become a mother. And that's my father holding my first child, his granddaughter, Isabel. His other value of education, he fully supported, and she is a junior in college back east right now. I miss her dearly. And the point of this is, my father didn't know the language of advanced care planning. He didn't know the specialty of palliative care. It didn't exist. He knows his values and he knows the importance of communicating them. And he planted a seed so that when he actually was approaching the end of his life, I was clear on how to support him and what mattered most to him. And it wasn't going down the green line. It was being home with his family. And I'll come back to that in a little bit. Oh, I have to, sorry, get my other technology. There we go. So often how we perceive ourselves may or may not be reflected in how people outside us see where we come from and who we are. Nowadays, we've heard a lot of hero talk. I'm not saying that's wrong or inaccurate. I'm just not sure that is what necessarily helps us sustain in the practice of healthcare that we find ourselves in today. And I might suggest that something that palliative care covets and necessitates is a team-based approach, that it's with our colleagues where we find the recognition of who we are and why we keep coming back to do the work that we do every day. And so here are some images of the team members I've had the privilege to work with thus far in my career. Almost everybody on this slide is a hospice or palliative care nurse. There are 2 exceptions, and I will let you figure out who they are. And you are welcome to put that in the chat or Q&A if you are that curious. So here's a polling question for you. You've heard me use the language, you've heard Jeannie use the language of hospice and palliative care. Fantastic. So a lot of people have had a lot of experience. Many people have had lectures, so that's more than I had in my own medical training. I can tell you, I will date myself, that palliative care didn't exist as a specialty in my medical training, and the words of hospice were only actually spoken by nurses. Never had a physician talk to me about hospice. So I'm grateful to see many people at least having some exposure. I had really zero. Even clinical rotations, that's outstanding. And then a lot of personal experience. So a little bit of fellowship training, opportunities abounding, growing every year by the minute for specialty training. So something to look toward if you get inspired by what you hear today. Fantastic. Thank you for answering. So one of the questions we saw early on was, what is hospice? What is palliative care? Are they the same? Are they different? I'm going to answer it for you right here. Feel free to use this metaphor. Take it with you for the rest of your life. I like to think of palliative care like a donut. This one is a particular donut. It's pink glazed. That's my youngest son's favorite. And so everything in the donut, everything that you can put your hands on before you put it in your mouth, that's palliative care. I'll explain what that is in a second, but just hold on to this. All of that donut is palliative care. The donut hole is hospice. So what that means, if we think of this like a Venn diagram, is while all of hospice is palliative care, it's contained inside the whole of that donut, pun intended. Not all of palliative care is hospice, just the donut hole. There's much more to palliative care than just hospice. Right? So I'll say that again, right? All of hospice is in fact palliative care. It's just a particular portion of it. Palliative care is much more than just hospice. All right, so here's where some of this confusion arises, is how do we reflect on where hospice and palliative care came from in the practice of it. When palliative care came into existence in about 2008 as a formal specialty, a board certifiable specialty, we saw that disease-focused care, cure-focused care, kind of went on this diagonal path, and as people became maybe less able to tolerate disease-focused care, palliative care would swoop in and take over until there would be this gentle transition to hospice. And again, I will distinguish what hospice is as part of palliative care. And then one of the unique features of hospice is the mandatory requirement for bereavement. You see that at the end. We've come a ways over the last decade since the specialty's been in existence. And part of it really happened because of this landmark paper a decade ago. This was published in a manner that got so much attention, being in the New England Journal of Medicine. It was on par with the way that new therapies get attention, new immunotherapies get attention. And I'll show you why. So this is a slide. I'm not going to go into the details of it, but it's really showing you something that relates to the concept of kairos. And what I failed to tee up in the beginning of the talk was the distinction of chronos, length of time, Greek for the length of time, and kairos, Greek for the quality of time. There's my phone, sorry about that. And this slide is looking at the fact that when you have people automatically given an intervention called palliative care, as compared to people who have standard disease-directed care that may or may not include the addition of palliative care, that kairos, quality of life, improves in a variety of measures. But here's what got the attention. Not that we don't care about kairos. In fact, if you ask anybody what matters most in life, not anybody, but just about anybody, the qualities that they'll give you are in fact quality of life measures. They're kairos. Very few, in fact, put chronos, quantity of life, as the key measure. But this is the graph that was the landmark, which was for those people who automatically got palliative care in the state of serious illness. Not only was their life not shortened, which is one of the major misconceptions of palliative care, their life was lengthened to the order that is equivalent for what gets drugs approved by the FDA these days. So 3-month survival advantage for those who received palliative care over those who received standard of care. And while we don't charge $100,000 per treatment cycle the way some chemotherapeutic agents do, we will give you a quality of life measure as well as, so you'll get the chronos with the kairos, which I'm not sure the chemotherapeutic agents can always say. So as a result, the paradigm of how palliative care is involved has shifted. And instead of it being this straight linear relationship, we recognize that there are ebbs and flows in life. And so we vacillate between when are we really focusing on addressing a disease state that wants to be halted or removed, and when are we addressing the total state, the kairos that someone is seeking. And how can we merge those in a way that then allows for hospice to appear not just at the last 4 days of life, which is when hospice showed up for my father at his request, but as an ongoing conversation our whole lives, where we can look and see what best supports us in all the things that matter most to us throughout our entire life. So here are some nuts and bolts for you. Hospice versus palliative care. Again, we're not in competition with each other. It's just a way to frame it. So first and foremost, as I said, it's a team sport. Hospice, being a Medicare mandated benefit, actually requires 5 team members: a physician, a nurse, a social worker, a spiritual care provider, and a volunteer are required for a hospice to actually be able to then be reimbursed by Medicare, and then all the private insurances follow those rules. Palliative medicine, on the other hand, since it's a specialty without a Medicare mandate, can only aspire to that team member structure. It's not required to. And for monetary reasons that I won't go into in this talk, sometimes that's hard to come by. Fortunately, in the VA system and things and systems like it, like Kaiser, the monetary structure can really support a team-based model, where private sectors currently seem to have a hard time doing that in the fee-for-service model that we still live in. Most importantly, a key distinction is that hospice requires the 6-month prognosis. And the way that's phrased matters. It means that a doctor has to be able to say, I wouldn't be surprised if you were to die in the next 6 months. And here's the key point: should the illness run its natural course? I can look at you and say, because of all the things happening, would I be surprised if I let the disease do what it's doing? I don't try to interject. Would I be surprised if you were to die in 6 months? That's what makes any individual eligible for hospice. If a doctor can say yes to that. Palliative care, on the other hand, has no prognostic requirement. It simply says, if you are living with a serious illness, or I prefer to say a life-altering illness, you might consider having palliative care involved. Now, that's a pretty gray definition. What's serious to you may not be serious to me, may not be serious to your neighbor. What's life-altering, similarly. And yet, the point here is palliative care wants to show up well before 6 months. And while hospice actually can exist long beyond 6 months, and again, that's a nuance for another talk, palliative care is meant to be really available our entire lives in that ebb and flow manner, because parts of our lives get much harder than others. And why not have this extra team support? As I mentioned, hospice is required to provide bereavement. Palliative care can aspire to that, and with the support of our chaplains like Jeannie, we may be able to succeed in that, but mostly we're not capable at this time. So here's a model of the interdisciplinary team I'm alluding to. First and foremost, this isn't unique to the specialty of palliative medicine at all. The patient and their family, however they define it, their community, blood-related, love-related, whatever, they're in the center. It's the only reason we show up. Without them, we can go play together, but there's no reason for us to work together. With them in the center, the only way to fully support someone living with a life-altering illness is to recognize that the experience as a human being is so multidimensional that one specialty trained person can't possibly be sufficient to support that person. Furthermore, their community, who they're reciprocating with, also needs support, because whatever they're feeling, their loved ones are feeling in their own way. And it's vice versa. So you need this 360-degree team of specialists around them. And so, as I mentioned, the hospice benefit identified that, mandated that, to include nurses, social workers, spiritual care providers, as well as the opportunity for licensed therapists, other home health aides, and many, many more. And the idea is, again, to recognize we are multidimensional, therefore we need a multidimensional team around us. Now, you don't need to be in a specialty team to create that team. It's the opportunity to recognize you don't need to have all the answers. Go find your partners to come support the people you're caring for with you. So that brings us to why. Why do we care for people? Why do we serve? And this is a logo that was created by a team of a hospice group that I worked with many years ago. And what I love about it is as we were wrestling with that question, why do we serve? Why do we do this? We got clear that it was more than just providing comfort. It's more than just mitigating distress. It's beyond comfort. We're here to do more than just make it okay. We're here to make wishes come true. And the way to do that is by asking, what do people wish for? What matters most? Now, a lot of palliative care has gotten pigeonholed in a way into a narrow window of defining what that question actually means. And what I'm pointing to is something called advanced care planning. And so a lot of the consults I get as a specialist are in the domain of, can you help this patient figure out what their goals of care are? What are they hoping for? Or this family is struggling. How do we know how to treat them? And so lots of attention and documentation has been created to try and address specifically healthcare advance directives. And so here's one example that I found as I was preparing for this talk and getting to know the community of the VA. And I'm curious, here's another polling question for you. How many of you are familiar with this document? Have you seen it? Anybody? Yes, no? Just have you seen it? Whether you've seen it in person as a tangible or you've seen it online, has anybody seen? It's either yes or no. There's no right or wrong answer. Okay, great. So unfortunately, it looks like many of you have not seen this document. That's okay. I hadn't seen it either until I went looking for it. What I can tell you in looking at it, a lot of time and energy and expertise has been poured into this. It's pretty astonishing, incredibly comprehensive, and I invite you, if you're inclined, to go and explore it. All right, so for those of you in the yes category, it's about 20% of you, then this question really will apply to you. And so that's the next polling question. Have you used the document? And what I mean by used is whether you have personally filled it out, whether you've invited a patient or family member to fill it out, or whether it's been presented to you by a patient or family member saying, here it is. So a few of you, we'd love that to perhaps change, although what I also hope you take away from this talk is maybe that's okay. Maybe that's okay that you don't use it or aren't familiar with it, and I'll tell you why. So that brings us to this picture. This is a photo of, yes, my father again. This is my father now in the Air Force. My father was a military man from a very young age. In middle school, I'm told, he went to military school. He loved the structure and the lifestyle and the intention that military life provides. And so before he was old enough to enlist himself, he got his parents' permission and enlisted in the Air Force. And this is an image of him serving, I'm told by my mother, a gathering of generals as they were flying, I think it was to Germany. And my father took hospitality very seriously. Again, as someone who loves to serve, he served proudly in any way that he could. And he created such an impression on the generals, and one in particular, that this general nominated him, advocated for him, listened for his skills and his passions in two ways. He first invited him or encouraged him or maybe even sent him, I'm not sure how it really works in the military, to go to Yale to learn Chinese. so that he would become not just a translator, but someone that could potentially actually be used in particular ways with this skill set. My father, I remember him telling me that it was such intense training. The expectation was that you would be awoken from a deep sleep and immediately speak in Chinese. That's how ingrained the language were to become in you. And my father had an extraordinary ear. I think the general also was such an advocate of my father's passions for wanting to serve and hearing him so completely. He encouraged him, and like I said, I'm not sure the exact way it works in the military, whether he supported him or directed him or instructed him to enroll at West Point, which my father did, only unfortunately to have to leave because he was found to have an ulcer. So he couldn't complete his education there. So as he went to school elsewhere, he found he really missed military life, and eventually, now old enough to enlist himself, he re-enlisted, this time in the Navy. And this is where he and my mother met. And I share this because this is another demonstration of advocacy, of listening for what matters most to someone and how to show up for them without an advance directive, no documentation, no formalization, really with listening and conversation. And so what my mother heard after she fell in love with him at first sight was that one of the reasons he was also in the military was that it would support his own ability to go to college. And that mattered to him. And so my mother said, I hear how important it is for you to get an education, and I will promise you, I will see that you get that. You don't need to rely on the military to do that. Advocating, hearing what matters to him and advocating for it. The other thing my mother did is that she recognized she was in love with him and he was in love with her, and wanted to advocate for their relationship, for their life together, for a future. And she said, I don't see how the military is going to give us the kind of life together that I want for us, that I hear we want for each other. You being deployed and taken away so many months at a time, years at a time. She's like, it's not going to work for this relationship. So she advocated for him to actually leave the service after that second 4 years in the Navy. And they became married, and she supported him through both his undergraduate and graduate schooling for another almost 45 years of extraordinary marriage. And so what this points to is the power of listening, and the importance, as that is the portal to then becoming an advocate. It isn't so much the form as it is beginning with the listening and the conversation, and having then the courage to speak what you hear and stand up for and advocate for those wishes coming true. And that brings us to the practice. How do we practice this practice of palliative care everywhere? You don't need to specially train, though I invite you to. It's a lot of fun. And this is something you can do everywhere, always, right now. In fact, it's actually something you've likely been doing your entire career and your entire life, as I've demonstrated with my own family, but maybe just not revealed to you as such. One of the powers and the skills in palliative care is naming things, saying what you hear, saying what you see. And by naming it, we reveal what's right in front of us. So practicing listening and naming and this courage of advocacy is at the core of palliative care. And so here's a little nuance for you. When we look at this number, before you learned fractions in grade school, probably, you might look at this, if I were to show it to a 6-year-old, they'd be like, what? Maybe I know the number 1 and I know the number 4 and I don't know why there's this line between them. But after you learned fractions, you're like, oh, that's 1/4. I don't know why there's a 1/4 on the screen, but I know what that means. It's 1/4. Now, when I put it with a little c, if you've spent any time in a kitchen, you suddenly know, oh, sorry about that. You suddenly know we're cooking. It's 1/4 cup. And your mind starts to think, contextually, I know what that means. I know what I can do with that, or what I should do with that. Now, for those of us who just play in the kitchen or aspire to do more in the kitchen, if we play enough, we might get to create something like this, like my family did for my birthday a few years ago. And they knew how to use the quarter cup, and they knew how to follow the recipe precisely and how to use the back of the knife to clean off that quarter cup without fail. But once you start to practice so much that you have developed a passion around it, where you live, eat, and breathe it, you don't even notice you're doing it anymore. Well, then you've entered into the world of art. And now you know when that quarter cup is meant to be precise and when that quarter cup is meant to be a suggestion. And maybe you want a little more sweetness, or maybe you want a little more savory, so you can change how precise that measurement is. And that's the opportunity to hold with palliative care, that caring for people is an art. There's science, there's knowledge you can bring to it, and then there's your whole self you get to bring to it, and what you like to add flavors or take away flavors. And this brings me then to the metaphor that I love of Dorothy in Oz, where she knew how to get herself home. She had the power. The minute she stepped into Oz, it just needed to be revealed to her. And the minute it was, then she got to make her own wish come true, which was to go home. And so I'll leave you with this brief story, which is a hospice nurse shared with me. He mentioned that many years ago, he and I were seeing a patient together. And he asked me at one point, how do I become a better hospice nurse, a better palliative care nurse? And I looked at him and I said, you don't need to become a better hospice or palliative care nurse. You don't need more training, more education. You just need to be human. We have everything we need to show up and to be present for people, just like Dorothy did in Oz. So my thoughts on some key takeaways, and I'm going to invite you to share your own, are how to listen, how to create permission for people to show up and speak freely so they know you're really listening and you're not going to go away no matter the story they're about to share with you. And that by your listening and bringing your whole self, your whole presence to them, you're going to be in a position to advocate for them to make their wishes come true. And sometimes that can be hard. And sometimes it can be amazing. And there is nothing better than doing that as a team, to sharing that with people, to being able to debrief with people, to being able to discuss and create new recipes with people. Did you add a dash of that? When could I bring in this flavor? Maybe you can help me. And everybody that's been at this conference is a team member waiting to happen if they aren't already one of your team members. And because of what we've learned from COVID and the virtual reality, despite the technology challenges at times, it's easier to create teams more than ever. We don't have to have borders and boundaries and walls that we rely on. We can go well beyond them. So with that, I want to invite you to stay curious, to not assume you know why someone's coming and seeking your care, your guidance, your time and attention, but to ask. And to trust yourself that you are enough to listen. You have what it takes. And you can advocate. You don't need a certain degree after your name. You don't need a certain training after your name. When you hear someone's wishes, you have the power to make them come true. And if you're ever in doubt, I encourage you to reach out to your friendly neighborhood spiritual care provider, because they have some of the most powerful magic and listening skills of any human being on the planet. So with that, I'm going to leave you with one last polling question to think about before we answer your questions. What might you wish to share with someone who wasn't able to be on or stay on this conversation right now? Let us know what you want to take away. So many gems. We like to sparkle in palliative care. That's nice. I like gems. You can have them all, by the way. You don't need to just limit yourself to one. Improved quality of time. Yes, it is about Kairos, right? Go beyond the training. Wow, I'm going to quote that. I love that. That's a great tagline. Go beyond the training. The conversation guide, if you can find it. We'll make sure to give you a link to that. Yeah, absolutely. Contact information will definitely give you that too, not to worry. Being authentic, yeah. We all have the ability to be authentic. You know, why bother being anything else? Unless it's Halloween. But you could authentically dress up for Halloween too. It's the opportunity, I guess. Be the authentic alter ego. Well, thank you. Please keep sharing. And I recognize I have no idea what time we want it to be at or where you all need to be, but I do want to invite questions, and we will absolutely be able to give resources after the conference for sure.
Great. Thank you so much, Dr. Gross. That was truly a very touching and informative presentation. I'm sure many of our audience members found it helpful. We do have a few questions for you. So one of them here is, how do you reconcile when patients and families might not be on the same page about end-of-life care?
Oh, I so appreciate that question. And I can feel the distress in the question. I think so many of us in healthcare find ourselves in that situation, witnessing it. And so one of the first things I try to do is, you're not surprised, is listen and ask questions, right? So I'm listening for what someone is wishing for, as well as what do they think is happening. A question that you will hear palliative care trained providers ask, but again, it doesn't need to be restricted to a palliative care trained provider. You can own this yourself. Is an opening question of, what is your understanding? What is your understanding of the illness? What is your understanding of the situation? What is your understanding of what will happen if we do this, that, or the other? What is your understanding? Opens up the conversation so we can start to tease out what these different family members' perceptions are, as well as their concerns, their fears, and most importantly, what are they hoping for? And more often than not, what we find is they are actually on the same page, and they are just coming at it from very different places. Mostly people are hoping to support their loved one. And when we get clarity on what that support then can look like, they start to see that they're aligned, that what's present is love, by and large.
I wanted to share just a brief story in response to that question, if I could. I was once working with a woman who was dying, and she had very clear ideas about what her end-of-life care should be for her. And I was with her and her sister, and her sister said, I wouldn't have chosen that for you, but now that I understand what you want and why you want it, I will make it happen for you. So it was the listening to what it was that she wanted, but also what was underneath it, as Dr. Gross said, what mattered to her about it. And then that gave her sister the comfort and the knowledge to be able to advocate for her in a different way.
That's awesome. Thank you, Jeannie.
Great. Yes, thank you so much for sharing that. That's definitely an important point that you mentioned, knowing what the patient wants. And so another question that we have here is, how do you recognize when a patient reaches that point where I guess they would need palliative care, not necessarily hospice, but some type of palliative care?
Yeah, such a great question. And I look forward to the day that I have a really definitive answer for you. There's a lot of research in the domain of looking for what are the key features of an individual's current healthcare situation that says palliative care now, so that it becomes just so clear. If we think about all the specialties of medicine, though, how do we know when it's time to bring in the cardiologist or the endocrinologist as compared to what we can know as a general practitioner? And it's nuanced. We all learn in medical school how to measure blood pressure, how to recognize when someone has high blood pressure, how to know when someone's blood sugar is high. But it's not so pristine to know, well, when have we tipped over into, I need a specialist to now manage that blood pressure or that blood sugar. And unfortunately, palliative care is gray. What I would advise you to consider is it is never really too early to inquire about palliative care. Depending on your system's resources, you may get pushback. But to inquire at least opens the door. And someone may say, they're not quite complex enough or sick enough. Let's start with what's considered primary palliative care. Let's reach out to your social worker and to your nurse on the unit and see how we can cultivate their skills to do primary palliative care as distinct from specialty level palliative care. On the other hand, if you don't ask, or you wait until you think someone is super sick, like they're already in the ICU for weeks, you may have waited too long to where palliative care and hospice can really make a difference. And I think that's what we see, unfortunately, is that where palliative care has been shown to make a difference is when we get involved early. That's what that New England Journal paper showed. And early is relative. This was 3 months before someone died, 6 months before someone died. We're talking 2 years, 5 years. When someone has a serious illness, they don't need to be dying from it, but their life needs to be rocked. Hospice, same thing. The average length of stay of hospice right now in this country is 17 days. It's not close to 6 months. We wait so long to make sure we think they're dying, and they miss out on the glory of having the opportunity to have their wishes heard and come true. So earlier is better.
Thank you. Dr. Blaustein, did you want to add something to that?
Only to echo what Dr. Gross said, that it's much easier to wait too long than it is to inquire early. And I would just advocate that if someone is suffering, palliation means to relieve suffering. So if someone is suffering, then that is a red flag for all of us to say, what could we do to help relieve this person's suffering? And if we get pushback, we get pushback. But it's definitely, as Dr. Gross said, worth asking and inquiring what extra layer of support might be added right now.
Great. Thank you so much. Those are definitely good points to recognize. And we have another question. Someone is asking from Mary Alden Goulart, how can we learn more about dialogue?
Oh, that's so sweet. Thank you for asking, Mary. So Dialogues, you can Google us, and I can also share with the community a link to our organization, but it's spelled with a Y, as you see. So just Dialogues. It actually has an S on the end because conversations are plural. It's never one and done. We're always in ongoing dialogues. So if you Google Dialogues, dialogues.com, you'll find us, and there's a link. You can be in direct touch with me via email as well, but I'll share that with the community at the end of the conference too. Thanks for asking.
Great. And then we have another question related to our veterans. So what is medicine's responsibility to dying veterans who are acculturated to homelessness?
Wow, that's a powerful question.
Yes.
So the first thing I just want to sit with the statement, right? Acculturated to homelessness. The epidemic of unstable housing where I live is out of control, but it misses this notion of acculturated to homelessness, and to me that speaks to how we institutionalize ourselves in any number of ways. How do we get used to the systems that have been made available to us or not? And I am not at all an expert of the Veterans Administration system And yet I recognize as a healthcare provider and have learned much from the VA system how we can be doing things better to provide whole person care the whole of their lives, not just to them as an individual, but to their community. And I think one of the opportunities is to create community, to remind our veterans that they came from an extraordinary community of the military, and that by being a veteran, the naming of veteran means you never leave that community. You are always part of this community. So how do we create that sense of ongoing belonging, accountability, responsibility, and meet people wherever they are currently acculturated? It doesn't mean they have to stay that way. People don't stay in a deployed state for their entire lives. They come and go. We find and adjust and adapt to new ways of living, horrific and humble, honorable and inspiring. And I would like to believe that the VA system can recognize that by naming a veteran, that we are constantly and forever inside of community with an opportunity to create and honor and support our community wherever they are.
I would simply add to that when folks find themselves in relationship with the medical system, in this case with the VA system, it's often not where they want to be. People want to be home, or they want to be where they have called home. And so I think our challenge when we meet these folks is to support them in trying to help them find their comfort in whatever ways we can, and in trying to listen to the things that they feel so strongly about not wanting to have a home, and how hard it is to suddenly be in an institutional setting when they want to be in the place where they have become, to use the language of the question, acculturated, or with that community. And so I think it's really about one of the words that Dr. Gross used earlier, about presence, about being present and letting people creating space for those folks to really be in their grief and their frustration and whatever it is that's coming up for them as they come in contact with the medical system at this moment in their lives. Thanks.
Beautiful.
Thank you both. That's so important. And we truly appreciate you both, Dr. Gross and Dr. Blaustein, for providing us with the tools and knowledge to have those difficult conversations and helping us shift the way we approach end-of-life care. We really thank you so much for joining us today.
Thank you for having
Now, our
us.
last session, sure. Our last session of the day is also pre-recorded. If you have any questions, please feel free to submit them in the Q&A tab, and we will share those questions with our speakers at the end of the presentation. Our next presenters are Dr. Kathleen Capitulo, who is the Associate Director of Patient Care Services and the Nurse Executive of the James J. Peters VA Medical Center in the Bronx, New York, and Dr. Linda Olander, who manages the Nursing Administration and Urban Policy and Leadership Program at the City University of New York, Hunter College, where she is a distinguished lecturer. Dr. Capitulo and Dr. Olander will update us on their research regarding veterans and vision health. Please enjoy this next presentation. Thank you.
I'm Dr. Kathleen Capitulo. I want to give special thanks to Jonas Philanthropies for their vision and support of veterans' health and doctoral nursing education. We appreciate the Jonas Grant that has enabled us to focus on veterans' vision and advancing the role of doctoral nurses. Today, we will share a project currently underway at James J. Peters VA Medical Center in the Bronx, New York City, improving veterans' vision. When we initially heard about the Jonas Grant opportunity to improve veterans' vision, Consistent with the Jonas mission, we immediately engaged doctoral nurses at James J. Peters VA. We coined this phrase, and they are nurses who have doctoral degrees or are current students in a DNP or a PhD program in nursing. One of them, the one with the little green indication, is actually a Jonas Scholar. The doctoral nurses have worked with both Dr. Olander and myself on all aspects of the project. In addition to improving veterans' vision, specific scholarly activities are planned for the doctoral nurses and nursing community, including a publishing workshop to improve writing skills, to increase the number of publications from this group, as well as an interprofessional conference to disseminate our findings and programs that improve veterans' health. James J. Peters is located in the Bronx, an inner city community within New York City. Its zip code is home to the highest rate of diabetes mellitus in New York State at 14.6%, and among the highest in the nation. As a result, the hospital cares for more than 20,000 veterans with diabetes. Veterans with diabetes are at risk for vision loss due to retinal damage. Veterans are at even higher risk with higher rates of hypertension, renal disease, homelessness, mental illness that all contribute to challenges with adherence in this vulnerable population. Despite these increased risks, we learned that retinal screening rates in veterans at the Bronx needed improvement. The objectives of our program were to identify issues related to veterans' health in veterans at JJP particularly, to identify barriers to care for veterans' vision, and to identify strategies to improve veterans' vision. This project will conduct a pilot of an evidence-based intervention to improve screening and will disseminate findings and change practice. We started our work with a literature review, and we found that vision issues in the veteran population of people with diabetes at James J. Peters had several components. We learned that early identification of issues used to increase retinal screening could prevent vision loss. We learned about other evidence-based strategies, and we will share one of them with you today. And we did a rapid process redesign of the retinal screening process for veterans with diabetes mellitus. We used the Six Sigma project redesign, and we flow-charted the results. We had multiple meetings using this methodology with the stakeholders, and we identified projects, leaders, and evidence-based strategies to improve screening. So we started with a kickoff. We had a grand rounds, and the leaders of the Jonas philanthropies did come to that, which was really very exciting and validated the importance of this work. And we started with a lunch and learn in February of this year. It was entitled Interprofessional Collaboration, Ophthalmology and Nursing, Improving Veterans' Vision Health. We have been working on this redesign ever since, with frequent weekly meetings with the doctoral nurses and the redesign team. And we are presenting to you. We appreciate being here as part of this important conference that Jonas is putting on today. We will be having professional writing workshops this November 2020. And we have planned a spring 2021 conference to disseminate the findings of this work, as well as other special programs for veterans' health. So in doing this redesign, we were able to identify initial barriers for retinal screening. And there were several of them. We flow-charted the current process, and we continue to work with our evidence-based colleagues to move ahead and identify a strategy. So some of the initial things that were really barriers to increasing retinal screening were the screening process at our hospital is cumbersome. Veterans don't get it at the time of a regular visit. They are told to return at another time for the screening, which requires another visit. Veterans with diabetes mellitus are not tracked to monitor adherence to make sure they got the retinal screening. We've had challenges with COVID-19, limiting access to in-person visiting. We've done lots and lots of video visits. And in fact, some veterans are afraid to come into the hospital, although things have opened up at about 40% at this point. Also, the current retinal screening camera is really bulky. It's very big and it's fixed to a desk and not mobile. So it's not something that we can just move around the hospital and have in one place to have opportunities for veterans to have exams easily without an appointment. And the process requires that the veteran have eye drops to dilate the eye to see in it. And that was a challenge because you have to have patience to sit there for 15 minutes while they dilate. And one of the challenges we have with this vulnerable population is they don't have a lot of patience and they want immediate care or they will leave. So those were some of our initial concerns. So now I would like to introduce Dr. Linda Olander, who will talk about the current screening process for veterans for retinal screening.
Thank you, Dr. Capitullo. I will now speak about the current retinal screening process for veterans with diabetes at the James J. Peters Medical Center. I will discuss our findings, and I will discuss a plan for the sustainability of this project moving forward. As you can imagine, meetings with key stakeholders is critical to the success of this project. In order to facilitate a dialogue between the key stakeholders and to establish common goals and a shared vision. So we really put all the players together, and there's a little bit of ownership between the different players that causes a lot of resistance at first. So it's important to allow time for the process and the discussions about the best way to achieve our goals. What we began to map out the current retinal screening process, and what we affirmed was that the majority of retinal screen eye consults for new patients with diabetes came from primary care, mostly. We also found out that both new and returning diabetic veterans interfacility consults and related clinical reminders were generated within the electronic medical record by a staff member, but not signed. So the process of getting signatures in a timely manner was a challenge. In fact, the delays in obtaining provider signatures within the electronic medical record was a common occurrence. And we learned that consults in the system for over 30 days were discontinued. These delays in appointment scheduling were very commonplace. And if we had a timely provider signature within 30 days, eye appointments were made, but the average wait time for an appointment was 5 to 6 weeks. Additionally, the clinic is on the first floor, and when you look in, it's overcrowded. And frequently, a number of veterans who came in on a separate day for this appointment would come in and leave because the wait time was too long, or would not show at all. We learned that a number of veterans, many veterans in fact, crowded the clinic for routine screening for eyeglasses. So that was a big problem as well. What we did was a cause and effect diagram. Aside from the overcrowding and long wait times, we looked for other reasons for why our veterans left the eye clinic abruptly or didn't show up at all, and we found many. First of all, as Dr. Capitula mentioned, there is no open access to the clinic. Thus, patients could not be seen the same day as their other appointment in another clinic. And so a consult was placed and needed to be signed and an appointment made on another day. Additionally, the dilation procedure, as Dr. Capitula mentioned, is lengthy and typically scheduled later in the day. And thus arranging transportation at a later time was difficult for many veterans. We had many transportation services for our veterans, but services through Accessoride and other similar services typically did not transport patients in the later afternoon hours. So patients did not want to wait. We also learned that many of our female patients were uncomfortable with the lack of privacy in this large waiting room that was overcrowded. Moreover, we learned that among many of our diabetic veterans, there was a knowledge deficit about the importance of retinal screening with a diagnosis of diabetes in this patient population. Enter an evidence-based new process, a new idea to provide point-of-care screening in the clinic area, specifically the endocrinology clinic, which was the selected pilot area to begin with. This is portable high-resolution camera, and we were able to collaborate with a telehealth technician who would screen the patients, or the staff would screen the patients, and the telehealth technician would upload the results of the retinal screening exams within the electronic medical record. And subsequently, the results would be read by the ophthalmologists from the eye clinic. So what were the pros and cons of this idea? Well, we did a force field analysis to look at the driving and restraining forces for this new idea. And to do this properly, you have to have the stakeholders, the staff, all in a room. What's good about this idea? What's bad about this idea? And what can we do about the negatives? So we determined that the driving forces included the likelihood of an increased rate and improved timeliness of the retinal screening. There would be a reduced number of unsigned or discontinued consults. There would be a reduced patient no-show rate, and the patients it would be convenient for patients to have the screening done at their endocrinology clinic point of care. The negatives, however, in addition to the anticipated, we don't have enough staff, because that's usually one of the most common responses you get at first for any new process. In addition to that, negative restraining forces included staff verbalizing that they weren't trained, and there wasn't enough space in the clinic, and there was an increased workload for the ophthalmologists. So we tried to address each of these negatives, looking at the daily workload, trying to find different days that were best, that had reduced clinic enrollment, and and we looked at existing staff and space available, also in nearby clinic locations and sharing of staff. We also established competency statements and related competency training and assessment processes. Next, I want to discuss the sustainability for a new process, and I like to use the I2E2 methodology for long-lasting change. With a vision of diabetic screening for retinal screening for diabetic patients. I1 is inspiration, I2 is infrastructure, E1 is education, and E2 is measuring the evidence. And I will briefly go over these. We all know how important it is to have a shared vision. And I can't stress enough that having those early meetings and discussing what the goals are and the commonalities, the vision among all players was critical to the success of this project. I1 of the I2E2 process is the importance of inspiration, getting everybody engaged, setting a go live date so people know when to be ready and when the project will start. And it's important to generate excitement. You really have to solicit the ideas from the staff. They're the experts at the point of care, so it's important to get their ideas. Typically, I will tell people, ask everyone, develop a communication tree and ask everyone, what do you like about this idea? What don't you like about the idea? And see if we can address the negatives. Signage is fun. It's important to have signage, a slogan, and most of all, have fun. You know, have a breakfast meeting, Halloween candy at the afternoon meeting, etc. I2 stands for infrastructure. This is really, I always tell people you need to build your change into the infrastructure for example, when you have an idea and you make a change and then you go on vacation, it is very common that your idea goes right out the window. People are too busy, they don't have time. But if you build your project into the infrastructure, it is likely it will be successful. And so developing pilot protocols, procedures, having IT help you with a screening tab within the electronic medical record for diabetics that automatically pops up that has to be completed, the screening. And you would need to get committee input or service approvals, and you would include the project as an agenda item in your clinic meetings and report the progress at meetings and in minutes. E1 of the I2E2 methodology stands for education for veterans and for staff at committee meetings, within select clinics, via newsletters, with progress reports, and as a town hall agenda item. And then E2, lastly, is evidence, establishing baseline measurements to be tracked. What are the current retinal screening rates? What is our no-show data? Our latest no-show data report shows that more than half of the consults, 56%, do not show up or walk out of the clinic. As Dr. Capitullo mentioned, our patient population is vulnerable. They are impatient at times. They have a lot of things going on with their health, not just about their eyes. And so it is important to, as I mentioned, provide the education about how important the screening is. And and work with these patients for alternate ways of screening. We would hope to see a dropped consult rate reduction, because consults wouldn't hang out in the system for 30 days waiting for signatures, because the screening would be done in the clinic, in this case the endocrinology clinic, but eventually in primary care clinics. And increased ophthalmology workload, which could be good or bad. I don't, the ophthalmologists may complain that they need additional staff, likely. On the other hand, they may welcome the increased workload. Those outcome measures, the no-show rates, the consult drop rates, the workload rates, all of those measures serve as an I-1 inspiration for the sustainability of the project. This is an iterative process. As you measure outcomes and you share those outcomes, that then inspires the team. And change in the infrastructure, in the education about the outcome measures, and in the evidence would be ongoing, and the process iterative in nature. Dr. Capitulo will now discuss next steps.
So what are our next steps to accomplish this project? We identified a process using a small camera that will enable retinal screening at the point of care, not requiring an additional visit or a long wait in the eye clinic. It also will not require dilatation of the eye with eye drops 15 minutes before the test. With help from the doctoral nurses who are assisting with facilitating, managing, and collaborating on this project, we have worked with the company who makes this camera to plan a 6-day pilot using the camera in the endocrine clinic. This clinic was selected because the two providers, a nurse practitioner and a physician, were early adopters, and the clinic population is primarily veterans with diabetes. Currently, we are collaborating with our IT department to upload the images into our electronic medical record. And we are getting approval for the camera to be used for the pilot. We're planning a 60-day pilot, followed by an evaluation, which will be done by providers on the quality of the images, by the patients on what they thought about it, and by reviewing the data to determine if this method increases our rate of retinal screening. So, we do have challenges getting it through our bureaucratic system, and we are, have some more challenges, but we are getting through that. We have one of our doctoral nurses is a nurse informaticist, so she's been really great working with the IT people to make this happen. And the other lesson learned that I wanted to share is this has been a very interesting experience working with ophthalmology. Ophthalmology at our hospital is very, very big, but they have never really done anything with nursing. They have one LPN in their practice that puts eye drops in before exams, but other than that, they had no relationship. They knew who we were, but I don't think they ever knew that we had so many scholarly nurses in the building that were doctoral nurses. And it has, in fact, been the doctoral nurses that have driven this project and gotten them out of the routine of what they've been doing for many decades into looking at something very different. So it really was an inspiration provided by the doctoral nurses that made us move forward. And it was this nurse informaticist who found this particular camera in the literature and was able to bring it forward to us. So it's been overall a really very interesting experience, very positive for us. So at this time, I want to appreciate all of you participating and being part of this very important program, and for all you do for veterans' health, whether it's in your family, in your neighborhood, or in a hospital. Again, we want to thank the Jonas Foundation and the Jonas Philanthropies for their support of this project, Veterans Vision, Veterans Health, and of course for their support of doctoral nurses. The Jonas Philanthropies have been incredible and have made the biggest difference in increasing doctoral education across our nation. So thank you, thank you, thank you. And if any of you have questions, if you would be so kind as to put them in the chat box, we will be happy to get back to you. Please include your email. Thank you.
Thank you to everyone who participated in today's conference. We had a great turnout with over 500 people registered. We hope you've gained practical knowledge and valuable tools provided by fellow healthcare experts. And we remind you that if you are seeking to earn continuing nursing education credits, please be on the lookout for an email next week with instructions.
We'd like to thank all of our presenters for their time and expertise today. It has been truly valuable. And we also recognize once again the support of the New York State Health Foundation. And we thank the Jonas family and the Jonas Philanthropies for their continuous support and vision for investing in nursing education and important health matters across all populations. Just to note, you will have access to the presentations that were just given for 60 days from today, and we will also be sending out an email with links and some of the references that have been discussed today. And I'd like to wish a final happy birthday to Mr. Donald Jonas, whose vision has benefited all of us here today. Thanks again, and have a great weekend.
Bye. Thank you, everyone.